O el primer y tal vez último hasta algunos meses. La verdad que costó un montón justo poder, o la organización, la Sociedad Argentina de Hematología y Novartis trabajaron un montón y hubo que rediagramar varias veces el formato de esta reunión, pero bueno, por suerte y creo que con el límite de tiempo, al límite llegamos para poder hacerla. Yo soy Federico Sackman, yo pertenezco a la subcomisión de las neoplasias mieloproliferativas crónicas y junto con la subcomisión, la sociedad y Novartis organizamos esta reunión. La agenda, el programa de hoy son 4 charlas que inicialmente se va a hablar de cómo estudiar un paciente con una neoplasia mieloproliferativa, cómo se lo estratifica y cómo los datos moleculares y la anatomía patológica pueden ayudar. Después, cómo los trata un paciente con mielofibrosis, un paciente con Polycythemia Vera. Después de un break vamos a presentar casos clínicos nuestros acá de Argentina y donde le vamos a pedir al invitado que nos haga sus comentarios y finalmente vamos a terminar con los temas destacados del Congreso Americano del año pasado. O sea, el lujo que nos estamos dando es de que nuestro invitado extranjero sea Verstovsek, es uno de los referentes internacionales más destacados. Por si alguno no lo conoce, él es médico, es oncólogo, profesor del Departamento de Leucemias de la Universidad del MD Anderson. Inicialmente él estudió medicina en la Universidad de Zagreb, él es de Croacia, después se fue a Estados Unidos. Actualmente es el director del Centro de Investigaciones Clínicas de las Neoplasias Mieloproliferativas del Anderson y participa activamente en la investigación básica y clínica, tanto en la biología de las enfermedades de las neoplasias mieloproliferativas como en el desarrollo de nuevas terapias. Es investigador principal de varios estudios clínicos, básicamente focalizado al desarrollo de nuevas terapias, y publicó muchísimo, todo relacionado a esto. Y algo que no es menor, también está involucrado en grupo de pacientes con neoplasias mieloproliferativas, mostrando también su interés en el aspecto más fuera de lo que es las drogas, sino la parte más humana y espiritual de estos pacientes. El objetivo de la actividad sería, bueno, mejorar nuestro manejo de pacientes con mieloproliferativos, mielofibrosis y Polycythemia Vera, compartir dudas, preguntas y experiencias personales. Al finalizar, va a haber una encuesta que siempre es importante completarla porque en base a las respuestas uno adapta o puede hacer modificaciones para reuniones posteriores. Bueno, y sin más, vamos a recibirlo a Verstovsek. Hello, Serge. Are you?
From Texas. I hope you can hear me well.
Yes, yes.
I'm sorry I was not able to join you in person. I was looking forward to it. I love to come to Argentina. It's a wonderful place, but it was not meant to be. We have a major problem here with the coronavirus and we are on a lockdown. But nevertheless, I'm very happy that we can communicate through the internet and that we will discuss the issue of myeloproliferative neoplasms. So thank you for the opportunity and hope this will be enjoyable to all. I know I will have fun to exchange experience with you in treating people with MPN. So without further ado, let me move on with the first part, which is, as you can see, diagnosis and risk stratification of MPNs. Can you see my slides?
Not yet. Yes, you are seeing the first one.
Okay, very good. So diagnosis and risk stratification of myeloproliferative neoplasms. We're going to start with some basics and remind everybody that the WHO classification of chronic Philadelphia chromosome negative MPNs have modified some of the diseases in terms of diagnosis and bring the knowledge of prefibrotic myelofibrosis to our attention. And these are the two major changes when we talk about WHO from 2008 to 2016. So in my presentation, I'm going to touch upon these two entities, which is masked PV and prefibrotic myelofibrosis. Everybody knows, I'm quite sure, that we are talking about the driver mutations in the MPNs, and this is a rather complicated slide to give all the information in one place on purpose, but this is common knowledge that we have driver mutations in the JAK2 gene, in MPL, and the calreticulin that are usually exclusive of each other and present to different degree in different types of myeloproliferative neoplasms. As we all know, on the right upper part, PV, almost everybody has a JAK2 V617F, occasionally JAK2 exon 12. ET, prefibrotic myelofibrosis or overt myelofibrosis, have a different degree of a JAK2 mutation, which is most common one, but then calreticulin, MPL mutations, and so-called triple negative, just as the background. As we all know, also, there are many, many other mutations, and some academic centers throughout the world, and not as a routine in a common practice. That is at least my experience so far. Do testing for other non-driver mutations, and there are many of them. This is just a partial list to give you a sense, and I'm quite sure that you know that, of the presence of different mutations that affect the function of the cell in a different way, and they're present in different disease entities to different degree. So they may affect epigenetic activity of the cells, signaling, splicing, or transcription. There are different types of them, and they may have actually an influence on what happens with the patient with particular disease entity. This is actually very well known. I'm quite sure that it is known that the degree of presence of additional genetic mutations, and this also applies to additional abnormalities in chromosomes, karyotypic abnormalities, is associated with aggressiveness of the disease. As you can see, here is again selection of the certain genetic abnormalities, just in that table that I put together, that would say that these abnormalities are rare in ET and PV and much more common in myelofibrosis and very common in blastic phase MPN, which would be acute myeloid leukemia, contributing to aggressiveness disease and leading to the transformation in some cases, where, as I highlighted on this table on the right side, the P53 mutations and also IDH mutations are much more common in the blastic phase, so suggesting a contribution of these mutations to a transformation process. So aggressiveness is tied to the genetic complexity. Let's put it as simple as that. Now, how does this inform us on the diagnosis and prognosis, the genetic abnormalities? Sometimes they do, sometimes they don't. For the diagnosis of Polycythemia Vera, the major change was not really to exemplify the presence of the JAK2 mutations, which is number 3 under the major criteria in this table. The major change is in decreasing the level of hemoglobin and hematocrit, as we all know, and there are a lot of discussions about it, and pulling the bone marrow biopsy as number 2 under the major criteria and suggesting that this might be mandatory. However, in fact, in that paper from 2016, in the small print below the table, it's clearly stated that the bone marrow is not mandatory in cases where there is obvious polycythemia vera with absolute erythrocytosis at very high levels of hemoglobin or hematocrit, like it used to be in a WHO classifications of 2008. And if you have a very high red blood cell count with the JAK2 mutation that can be tested on the blood, is the same between the blood and bone marrow, and a low serum erythropoietin level, which is minor criteria, then it is a PV. You do not need a bone marrow biopsy by a mandate if it's obvious polycythemia vera based on these factors. On the other hand, I also explain quite often to my patients when they ask me about the risk of transformation to myelofibrosis or acute myeloid leukemia, particularly transformation to myelofibrosis that can happen in about 20 to 25% of the patients during their lifespan, that the presence of the fibrosis at the time of diagnosis, which can be at the grade level 2, in about 20% of the patients at the time of diagnosis, gives us some information about a risk of transformation later in the life of that patient to overt myelofibrosis. So there are some prognostic factors, if you like, in that bone marrow that are informative to a degree. It's all relative, of course, and that would be presence of the fibrosis at the beginning. Again, it can be grade 2 in about 20% of the patients with PV. And of course, analysis of chromosomes can be done on that bone marrow sample. And there are about 5% of the PV patients that have abnormalities in chromosome at the beginning. This is informative for the future, not for the management. And when we explain that to the patients, most of the patients would like to know what the state of the bone marrow is at the beginning for the future. Okay, so what is the masked polycythemia vera? The reason why the hemoglobin and hematocrit levels were lowered is realization that there are patients that are not meeting that high threshold of hematocrit and hemoglobin over 18.5 or higher, so really high levels, and they still have a polycythemia vera. In that setting, in particular, where you have a high normal red blood cell count, and you have perhaps a suggestion of polycythemia vera based on the JAK2 mutation and lower erythropoietin level, but you are not absolutely sure. Patient presents perhaps with high platelets, and you are discussing it, what it is. Is it ET or is it PV, masked PV? Then in that case, bone marrow biopsy would be very informative, because that would be clearly separate the cases of ET, where there should be normal cellularity, from masked polycythemia vera, where there should be hypercellularity and a lot of other abnormalities. This is actually projected on this particular slide. The bone marrow biopsy, again, comes very handy when we are not absolutely sure about polycythemia vera case, particularly when the red blood cell count is high normal, and you have a suggestion of polycythemia vera based perhaps on lower MCV or lower erythropoietin level, or high white cell count that is unusual in ET. Then the bone marrow will discriminate usually very clearly based on these findings between ET and PV. That's why the bone marrow biopsy was brought up to a significant level to suggest that almost everybody should have it. Okay, now ET versus pre-fibrotic myelofibrosis. This is the standard comparison between the diagnosis between the two. And remember that pre-fibrotic myelofibrosis patients were actually carved out of the what we traditionally would be calling ET patients. That's how it happened in the past, almost 10 years ago. And so it really is a comparison by the eye of hematopathologists between the bone marrow morphology between ET and pre-fibrotic myelofibrosis. But the minor criteria can always help. And this is in the bottom of the slide in a red box. Here we have some anemia or some leukocytosis or some splenomegaly or some elevation in LDH as the minor criteria for pre-fibrotic myelofibrosis that may help the eye of the hematopathologist by bringing those minor criteria to our attention and saying, yes, this is pre-fibrotic myelofibrosis and not ET. So a combination here between the bone marrow morphology, the molecular testing, which is pretty much similar, and particularly paying attention to the presence or absence of minor criteria will help us in distinguishing these two entities. However, the question is, what does this actually matter? Does it matter in the management of the patients? And when the diagnosis of pre-fibrotic myelofibrosis was brought up to our attention as a full-fledged diagnostic entity in 2016, we had an influx of so many patients where they were diagnosed with pre-fibrotic myelofibrosis and got scared that the lifespan is 5 years and they need a transplant right away. I always like to bring this seminal paper to our attention. This is the one that led us to actually incorporate pre-fibrotic myelofibrosis as the disease entity. And the left side, there is a comparison of the survival of true ET patients, which is normal when compared to the healthy population of the patients about the same age. And in red color, this is on the left side, is the survival of the patients with early prefibrotic myelofibrosis. And it is on average about 15 years. So it's not 5 years or 7 years. We know that, but patients don't, and many times there is a confusion. So the survival is not that bad. Obviously, it's shorter than expected, but it is not that bad. And if you look at the right side, I utilize this information in my communication with patients and colleagues to say that the survival is 15 years, and after 15 years of median follow-up, 15% of the patients with prefibrotic myelofibrosis transform to fibrotic myelofibrosis. This is right upper part, and 10% would be transforming to acute myeloid leukemia. So not that aggressive condition, and the management should not be like fibrotic myelofibrosis. What is the management of these patients? It is mimicking essential thrombocythemia, not thrombocytopenia. I'm sorry about the misspelling. And bleeding and thrombosis are the main issues here that needs to be addressed. So assessment of the risk of thrombosis in prefibrotic myelofibrosis and management similar to patients with ET. Only minority of the patients have symptoms and the spleen and should be managed as patients with fibrotic myelofibrosis. So that's the part on the prefibrotic myelofibrosis. The difference between the prefibrotic myelofibrosis and fibrotic or overt myelofibrosis in terms of diagnostic criteria is basically based on the presence or absence of the different grades of fibrosis, which is the second row in this table. And the minor criteria includes leukoerythroblastosis as another entity, as to help us in distinguishing between the two entities. But typically, clinically, most of the time, it's quite clear what patients have. With a higher grade of fibrosis, there is much more anemia, much more of the splenomegaly, higher LDH, and leukoerythroblastosis. So it's clinically not that hard to distinguish between the two. And the last slide with all this text here, which has to be shown, is the criteria for transformation from ET to NPV, transformation of ET NPV to myelofibrosis. Now remember that Polycythemia Vera patients at the time of diagnosis, in 20% of them already have a grade 2 fibrosis. So the fibrosis can be seen in the more benign conditions. And we know from our own practice, if the patients with ET lives with ET for 10 or 20 or 30 years, and you do bone marrow, at that time, there might be some fibers there. The presence of fibers does not automatically mean that patient has transformed. That is such a common problem here. We have patients like that coming through the door saying they have transformed because somebody after 15 years of living with ET decided to do the bone marrow and there are some fibers. The other factors needs to be fulfilled for transformation to be complete and to label patients as transformed. And that transformation process takes time. So if there are some fibers in patients who live with ET for 20 years, you will look for, I'm sure you will, for presence of other factors, as you can see, leukoerythroblastosis, spleen, anemia, and others, to say whether there is transformation or not present at that point in time. Moving on from diagnosis to prognosis. In ET and PV, traditionally we would be using, and this is in any textbook, two factors that would be assessing what is the thrombotic risk in that patient, because thrombosis is the leading cause of death in ET and PV, so we want to control that risk. And as we all know from the textbook, usually it says age over 60 and previous thrombosis, and you divide patients in low risk and high risk. High risk usually means that you need to prescribe the cytoreductive therapy to that patient with ET and PV to control the blood cell count. What I like to highlight on this, not the novelty of any of these, but the bottom of the slide says extreme thrombocytosis is associated with the risk of bleeding. The platelets of 800 or 1100 are not on its own a risk factor for thrombosis. Many are worried about, in the younger patients in particular, of platelets of, let's say, 1 million, when there is no real evidence that the platelets are associated with thrombotic risk. They are associated with the bleeding risk when they reach a level of 1.5 million or higher, when we have association with the decreased 1 Willebrand factor. This is acquired 1 Willebrand factor deficiency leading to the bleeding risk. So no thrombotic risk, but the bleeding risk. Okay. Now, what's the impact of the mutational status on the thrombotic risk in ET? This really informed recent modification in prognostication for thrombotic risk in ET. This is one of the studies that I'm showing here on the left side. The calreticulin positive patients have a much better thrombosis-free survival. The same for wild type. If you look to the left side, in red, calreticulin, in green, wild type. This has been seen in several studies and led to modifications of our thrombotic risk assessment for ET. But I'll take this this opportunity also to talk just a little bit, like a digression from the prognostication, to address this wild type ET. This is triple negative ET. If we do a little bit more of a genetic testing in these patients, we would find that in these triple negative ET patients, there are patients that have abnormalities in other parts of the JAK2 or MPL genes. So more precise testing, NGS testing, the whole gene sequencing might find abnormalities compatible with activation of one of these driver mutations, even in the triple negative ET patients. So that is being done in some of the academic centers. Going back to modifications of the thrombotic risk in ET patients. You may be familiar with that already. It is also endorsed in United States by NCCN guidelines published last year to extend the number of risk factors to consider when you assess thrombotic risk in ET. In the middle of the slide, there are now 3 factors: age, previous thrombosis, and JAK2 mutation positivity. Most of the people check for JAK2, not too many have even possibility of checking for many other mutations or other driver mutations. So that's why, to make it simple, it is the addition of the JAK2 V617F mutation information, yes or no. And you see that all the risk patients that will be younger than 60 and having no history of thrombosis are now divided in two parts. Very low risk patients, so no JAK2 mutation, which would be calreticulin positive basically, and they have no history of thrombosis. The issue is, do you even give them aspirin anymore, right? So 45-year-old calreticulin positive patients with ET, aspirin or no aspirin. Suggestion from our Spanish colleague is that no aspirin is fine. There is no benefit from aspirin in calreticulin, otherwise low-risk patients. If you have a JAK2 mutation, you do give aspirin. And if you go at the bottom of the slide, all high-risk patients, those that are over age of 60 and or had a previous thrombosis, are divided again to intermediate risk if the age is the only factor. So let's say you have a 70-year-old calreticulin positive patient with ET, no cytoreductive therapy is suggested because there is no much benefit of it in calreticulin positive patients. Otherwise, the patient would be on cytoreductive therapy. So this is something that is being modified in guidelines. As you see, in the United States, we included that. That should be perhaps becoming standard practice, and further confirmation perhaps it's necessary, but there are quite a few papers suggesting that this to be proper way of management, and that's why in the United States we applied in our guidelines. Are there any factors, additional factors molecularly that appear to be important? Yes, but this is really not in everyday management, and it's something to pursue perhaps in the future, and this is the JAK2 allele burden. Typical JAK2 allele burden, the number of cells with mutations in ET patients, is about 15%. The number of JAK2 allele burden level in the PV at the beginning is typically about 45%. And it says in several studies, this is one of them, if the JAK2 allele burden goes above 75, that patient is more prone to thrombotic and hemorrhagic complications or progression. Do we do anything about it? Not even many can test for it, and we don't have real guidance or implementation of this information in the guidance to do anything about it. Something that is coming along for the future. What about other mutations? If one would do NGS and test for the spectrum of other mutations other than the driver mutations, you will find occasional other patient with other mutations. Not very common, as I mentioned at the beginning, but some of these have been shown to affect overall survival or transformation risk to myelofibrosis. This is not the standard practice. It is in the guidelines if it is done to note that as information, but we don't even have any medication to alter the overall outcome of the patient. So really it's information that has no real practical value, and we do not advocate testing for non-driver mutations in ET and PV. But it's good to share this with you. Moving on to myelofibrosis. Everybody is probably aware and utilize standard classic prognostic scoring systems, IPSS, DIPSS, DIPSS plus. They are summarized here. They do not include genetic information. They do include DIPSS plus does karyotypic information, which many times is not easy to get from the sample. We try sometimes to do that on blood for completeness, but the purpose of the prognostication needs to be understood. It is really to identify patients that have a life expectancy less than 5 years and refer the patients to the transplant. It should not be really used for any other purpose. And I'll talk about this a little bit later. But certainly with the number of prognostic scoring systems, we are getting complexity of the prognostication vividly explained to us as a problem. We usually like to prognosticate in a simple possible way and make it easy for the involved doctor and easy to tell the patients what the prognosis is, if we are to talk about this. And then if we apply prognostic scoring systems that we have, and this is just a selection of these 3 classic ones, then you can appreciate how the patient may belong to different prognostic groups based on which prognostic scoring system you utilize. You may criticize this paper that comes from Spain, from analysis of a myelofibrosis patient registry in Spain, saying that IPSS should be at the beginning, DIPSS later, and DIPSS perhaps is better than DIPSS. But you know, the applicability of these prognostic scoring systems really vary from one setting to another, and people are really confused. And this kind of reassignment of patients based on different prognostic scoring system confuse people even more. And then we introduce the genetic information to this prognostic scoring analysis. And we know at the top of the slides that calreticulin positive patients have much better outcome than a triple negative. That's probably widely known in the upper part of the slide. And if we do have NGS information with the genetic panel testing, then in the lower part of the slide, we may identify what we call high molecular risk mutations that we can add to the prognostication and make it even more complex, but perhaps more refined. With that information, you get extra degree of complexity. Not to say that there are 2 types of calreticulin mutations, which are informative for myelofibrosis patients, where there is a smaller group of myelofibrosis patients that have a type 2 calreticulin mutations. You can see this in the red color here. They have a worse outcome than type 1 calreticulin mutations. In many prognostic systems, this is not really clarified that very well, because the number of patients with the type 2 calreticulin mutations is rather small, right? Occasionally, most of them have type 1, so it's simplified, at least for that mutation, to just say calreticulin positive is good. Well, not in every single case, but in general, that's okay to accept as a notion. How many patients that have these other high molecular risk mutations? Do we need to worry about them? And the number of patients really is high. You see that about a third to about 40% or 45% of the patients with myelofibrosis can actually have a presence of 1 or even more of these high-risk molecular mutations. So identifying them and including them in prognostic scoring systems is valuable when we talk about referring patients to bone marrow transplant in particular. And therefore, we know, and perhaps some of you use MIPSS 70. This is the one that includes additional prognostic scoring factors. One actually needs to go online to plug in that information. That the website is in the left upper corner. This is where one can go and plug in information if you have all of this. This includes even bone marrow fibrosis, by the way, which is open to discussion. Number of these factors are open to discussion. Are they really solid or not? But nevertheless, if we would like to enhance our ability to prognosticate, one can combine all this together. We know that there is MIPSS 70 version 2 and MIPSS 70 plus that are out there as well. I am usually open to critique myself and other in the field of making it even more complicated with the number of prognostic scoring systems rising as we speak. Every year there are a few extra new ones in publications, so which one to use? The argument is that with the new prognostic coefficients, we are better. And here is an example where MIPSS 70 assignments, which is on y-axis to low, intermediate, and high, would alter how we assign patients risk based on IPSS. IPSS assignment is in the colors. The blue is low, or yellow is intermediate 1, gray is intermediate 2, and red is high risk. So with the refined prognostication, including all these other factors in MIPSS 70, the claim is that we are improving the prognostication of these patients. And this is version 2, not to go in detail, so even the MPSS 70 is getting updated. I hear that MIPSS 70 version 3 is coming along later this year. There is also MySEC-PM, which is suggested to be used for a secondary myelofibrosis from ET and PV. This is another one that requires going online. In the left upper corner is the website where you can plug this information. Interestingly, this one does not include, if you look at covariates, it does not include information on the high-risk molecular genetic abnormalities. So I actually asked Dr. Passamonti, who actually was involved here with that. He says because it's not standard practice to do it, so they wanted to make it simpler, which is a reflection of the practice. Not everybody does all this testing. That's a very important point, right? There is limitations in what we can do. And then there is genetically inspired prognostic scoring systems, just to give you a flavor. I'll talk later on what we do here and how we go about this. And then there is a classification and personalized prognostication based only on the genetic information. New England Journal of Medicine paper, I'm sure that you are aware of that as well. So there are so many of them, and it's a little bit confusing. And perhaps later on, when I talk about how we do that, we'll have some practical input even from you to see what do you do and what is cost effective. After all, it is about cost effectiveness. And we are not done. There are more genetic testing that one can do. This is from our own analysis of presence of additional variants, genetic variants in the JAK2 gene on top of the JAK2 V617F. How did that happen? Here, our standard practice is not only to test patients for the JAK2 V617F, the whole JAK2 gene is analyzed as a part of the standard practice. So what you get is you get JAK2 V617F mutation if the patient has it, but you also get information or presence of additional variants that can be present in addition to JAK2 V617F. So then we ask the question, what does this mean? And here is the paper from last summer. If you have additional abnormalities in JAK2 gene, then your outcome is worse. So I can tell you, we are not done with prognostication. There will be more prognostic scoring systems in place soon. And are we prognosticating well? We are actually we do not prognosticate very well. This was analysis of practice here in the United States. 500 charts from community oncology setting in United States last year. A third of the patients did not receive any risk categorization and diagnosis at all, which I would understand in some cases. If your patient is 75, 80 years of age, no transplant, why would you prognosticate? You go about the symptoms and the signs. But the lower part of the slide is more problematic to me. Half of the patients that were actually receiving prognosis based on some risk assessment received that based on a clinical judgment of the doctor without looking at the actual data. So physician-assigned risk categorization was done in half of patients, and it was super optimistic, just telling the patients you're doing well when the data does not support that notion. That bothers me much more. We are doing prognostication, but not the way that it should be done. So there is a room to improve in everyday practice. And why are we prognosticating? Simply, I want to emphasize this one more time. It is because we want to identify patients that have a shorter life expectancy than 5 years and be referred to the transplant. We are many times faced in our practice with some regulations that say that only high-risk patients can be given certain medications, like pills or injections. This we have overcome in our United States guidelines, saying that the risk of dying should not be associated with the prescription pattern to control the anemia or big spleen or symptoms. That is sometimes difficult to dissociate, but that is one clear message of our United States guidelines. The risk of dying has nothing to do with me treating patients with the symptomatic splenomegaly. At the bottom of the slide is the bottom line of all this discussion and prognostication. Less than 10% of patients undergo transplant. So really, all of this information is applicable to a minority of the patients. Once you do the transplant consult, the patient is ready, then there is the other side of the coin. This is a question of the success of the transplant itself. Only now we are talking serious discussion about the prognostication for the procedure itself. Everything so far that I was talking about is usually associated with the referral to a transplant doctor, because this transplant prognostic scoring system that I'm showing is including in a table you see HLA mismatch unrelated donor as a factor, right? So the type of the donor, the comorbidities also, Karnofsky's score and stuff like that, that is not included in what we have talked so far is important for the outcome of the transplant. So that's the other side. What's the outcome of the transplant itself is the question, and this is being addressed with new prognostic factors and new scores. What about the mutations in the everyday management? Apart from prognostication, what else can we learn from what I have heard or talked about so far? So we know that the JAK inhibitors, we are talking about the Ruxolitinib, is effective for the spleen and for the symptoms independently of JAK2 mutation or any other mutation. Unfortunately, I see here in the United States still, for some reason, a belief in occasional patient that is referred to me that only those with the JAK2 mutation should be responding to JAK inhibitor. We all know that's not the case. The JAK inhibitors are not specific for JAK2 mutation. They're equally active in patients with calreticulin, MIPL, triple negative, or JAK2 mutated patients. And one does not need to know actually what the driver mutation is to treat the patients for symptoms and the spleen. So outside the clinical study, we do not usually advise genetic testing or looking at the JAK2 allele burden, for example, decrease, and the information on the presence of the high molecular risk mutations really does not alter the approach in our management to patients with a big spleen or symptoms when it comes to JAK inhibitors. They have a good chance to respond as well. Now, if we do genetic testing, then there might be some other mutations or a complexity of mutations that will tell you, while you are treating patient with JAK inhibitor, whether the effect will be durable or not. So this is not a chance of a response. This is really telling whether the durability of response will be there. And our experience, which I show here from 2015, has been recapitulated by several other groups, which did not really find the same mutations. There is overlap in those. But this is just to say that a message that the genetic complexity really does, after all, affect in some way or the other the benefit of ruxolitinib. And in this case, I'm talking about the durability of the response. The real implication of this kind of testing, if it's done, and we don't really advocate this to be done, it's expensive and there is not really much you can do. But what you can do if genetic complexity is there, to advise the patients to go to the transplant sooner rather than later. And sooner means when there is the best benefit to ruxolitinib, because then the transplant outcome is usually much better for overall survival even after the transplant. So that's the implication of this type of testing if it's done ever in the community setting. After ruxolitinib, we can also prognosticate. We can say that patients after ruxolitinib have overall, in general, low survival or short survival. Our own publication from a few years ago showed 14 months survival. Recently, in December, there was a large analysis of the Italian patients saying that the survival is 27 months. We know in that setting, the patients with low platelets and patients with additional new mutations that are acquired while they live on therapy with ruxolitinib will impact their overall outcome. So genetic complexity again contributes to the prognosis of these patients. And in everyday practice, we don't really like to wait for ruxolitinib to stop working, and I will talk about this later in the other part of the talk. So in the summary of this part, we talk about diagnosis, prognosis, and impact of mutations on what we do. We are obviously cognizant of a clonal nature of the disease, that there perhaps are multiple clones, and they may be competing each other. The disease is not static in any possible way. The application of a driver and non-driver mutations presence or absence can impact on the management, particularly these days in ET, less in PV. Prognostication for myelofibrosis is definitely affected by this information, and referral patterns to transplant is increased, particularly in intermediate 1 or low risk patients by the standard prognostic scoring systems, where we then add the genetic information. And if there is a high risk mutation present in otherwise intermediate 1 or low risk patients by IPSS, we talk about the transplant sooner rather than later. That's perhaps the best situation where to apply genetic information for everyday practice in MF. So I hope that this was useful as a part 1 of the 3 parts that we're going to be talking today. I thank you very much. We're going to take a little break here.
¿Tenemos tiempo para alguna pregunta que quieran hacer? Las preguntas pueden ser en castellano, hay traducción simultánea, o pueden ser en inglés, o sea, como estén más cómodos. ¿Hay micrófono? There's some question now, Sergio. Acá.
How do you treat now pre-myelofibrosis?
The pre-fibrotic myelofibrosis patients typically present with high platelets, and we would be applying IPSET, International Prognostic Scoring System for ET, to pre-fibrotic myelofibrosis. You may be aware that Dr. Barboui at American Society of Hematology meeting had actually oral presentation on the applicability of that prognostic scoring system for ET that I showed on the slides, the applicability of this prognostic scoring system for pre-fibrotic myelofibrosis patients, and it does apply very well, which I'm not surprised because these patients were carved out of the ET patients. So almost everybody, great majority, that's perhaps better to say, are really presenting with high platelets and not much of anything else. They may have a little bit of anemia, as we said before, maybe a little bit of the spleen, and perhaps slightly elevated white blood cell count, but the real clinical need is to address their thrombotic risk. Now, there are patients, not to say that everybody is the same, in prefibrotic myelofibrosis space that are much more advanced. They have perhaps other genetic abnormalities, they have bigger spleen, they have more symptoms. We do also look at the IPSS at the same time and see whether this particular patient has features of a more aggressive type, even though it's prefibrotic myelofibrosis, to manage in a different way and even talk about the transplant if there are factors that would say that this is much more aggressive case. But that is minority. So majority is thrombotic risk assessment like ET, minority is like overt aggressive myelofibrosis.
Okay, thank you. I have a question. When we are diagnosing a patient, generally the pathologist asks us for clinical data. They want to know clinical data. And here we can have two situations. We can say, the pathologists say that clinical data may help them to make their diagnosis or interpret what they see. But in the other way, some clinicians might think that giving clinical data might influence or squeeze the pathologist's diagnosis. What is your position? How do you see this situation? Would you like that your pathologists have clinical data to make inform their analysis, or do you prefer an objective inform and you, with that, evaluate the diagnosis?
This is a really important practical question. And I can tell you how we overcome that issue. We have a meeting every Tuesday at noon where we analyze all together all the new patients that come through the door for all kinds of the diseases, including myelofibrosis or ETR-PV, to make a diagnosis together. The classic case is really a diagnosis of myelofibrosis, because for diagnosis, you need to have bone marrow, but you also need to know whether the spleen is big, whether LDH is high, whether the patient is anemic, and have a left shift, right? So if our hematopathologist doesn't have that information, the sign out of the bone marrow says MPN with fibrosis, and they will not tell you which type. It's up to you. And that MPN with myelofibrosis or MPN with fibrosis can be PV, right? As we said before. Some PV patients at the time of diagnosis have fibrosis. So it is important to combine the clinical physical exam, chemistry, and blood cell count and bone marrow fibrosis or bone marrow assessment all together. And we do this as a team meeting together. Maybe not today because we are separated in all our offices because of the problems here, but otherwise that would be the best. So sharing the information, whether you tell them or you are on the phone, is the only way to best define the case.
Okay, thank you. There's another question.
Yes, hello. It's been shown that patients with P. Vera carrying the JIT2 mutation do not respond well to interferon therapy.
Yes.
Would you suggest that we should study this mutation in every patient we are going to treat?
Really very good question. There is not much out there in terms of analysis of the genetic prognostication as it applies to different therapies in PV. And what you bring out is really important information. You are also then aware, since I see the question is really precise, that even during the therapy of PV or ET patients with interferon, there is a possibility of a clonal evolution, and presence of that complexity will actually affect the overall outcome of the patients who is under therapy with interferon. There is a limited number of papers on that, maybe 2 or 3 out there, and so it's not widely known. I'm glad that you bring this up, and it is not widely studied. Prospective studies I'm not even aware of where this is one of the major points, but certainly has, obviously, as you point out, implication for the overall outcome of the patients. So I would certainly encourage to study patients with genetic analysis while you are treating patients with interferon, as we do, for example, on the studies with the JAK inhibitors, to see what happens. And that would enhance our ability to inform what the patients will experience, what kind of benefit with interferon. The limitations of that are twofold. One is the cost, obviously, and then the other one is justification of the test to say, I'm going to be doing something else. That's usually tied to each other. If I say, I'm going to be doing something different for that patient because of this genetic information, then you can justify the cost. but we do not have too many options. The number of medications or options in general is low. So once we improve one aspect or the other, we will then improve our management style.
Okay, thank you. We have another question.
Good afternoon, Dr. Verstovsek. These are two questions about thrombosis in patients with PV usually, or masked PV. Splenic vein thrombosis in a patient with CHAC2 positivity and no other obvious component for myeloproliferative disorders. Let's say, what is your usually suggestion for long-term anticoagulation? How long? And the second question is, do you use new oral anticoagulants in these situations?
Excellent questions. These are very important for everyday practice. We see occasionally patients like that. We are in a cancer center, so we don't have a very large cohort of patients. Among about 2,500 patients with MPN over the last 10 years, there is a smaller number of patients like you described, but this is such an important question for everyday practice that we work very closely with our benign hematology department as well when they see something like that in other departments, like after surgery or so. Now, with the splenic vein thrombosis and JAK2 positivity, our standard approach is to utilize anticoagulation for the rest of their life. They may or may not have the MPN in the bone marrow. We typically would be doing the bone marrow to see whether there is disease or not. And as you know, 50-50 chance, let's simplify, right? 50-50 chance to have a bone marrow involvement to some degree or not. It may not be obvious at all clinically, but if you do it, you see some myeloproliferation. You would certainly follow that patient even if the patient has normal bone marrow, because again, 50-50 chance that that patient will develop in due time MPN after 5 or 10 years. So they're predisposed in a way to have a disease perhaps later, right? This is this clonal evidence of clonality without overt disease, kind of chip in a way, right? That will perhaps lead to the disease later. Practically so, anticoagulation, our benign hematology doctors that specialize in the anticoagulation tend to use new anticoagulants, and I don't have a preferred one to say, but they are much easier to manage, and they would be then giving the pills, apixaban or some other ones for the rest of the patient's life. I would be managing patients by seeing the patients, let's say every 4 or 6 months to see about possible progression and abnormalities that would lead to obvious presence of the disease. If the disease is present already, then the question is whether you need to do cytoreductive therapy or not, right? You have, let's say, the bone marrow that shows myeloproliferation. It's unclassifiable MPN. You cannot say whether it's ET, PV, or MF because there is nothing really there, but it is evidence of MPN. And blood cell count is normal, right? But it's MPN in a bone marrow. So the question is, what is the cytoreductive therapy for, right? We have discussions about this quite often, and I always go to my teachers, Dr. Barbui, which is an amazing guy, right? They are a godfather of clinical management of patients with ET and PV, and I call him up and say, Tiziana, what do I do? And he says, treat the patients with cytoreductive therapy. And I say, what I am treating for? Well, you treat the patients with cytoreductive for 2 purposes, right? One is to decrease the blood cell count. The other is to decrease the inflammation, right? So if you have let's say, white cell count of 8, you will go and you treat and lower it to 6 or 4. If the platelets are 350, go to 200. Decrease the proliferation, but there is also anti-inflammatory part of the cytoreductive therapy. So do something in addition to the anticoagulation. That would be my approach. I learn as I go through my life.
Okay, thank you. So I think there's no more questions. We may move forward to the next topic.
Very good. So, do you see my slides? Yeah?
Yes.
Okay. Okay, so in the myelofibrosis part, and so there are two parts. There will be a few slides at the beginning that I have already shown just to give you my take on how we do it and what we do with those, and not to go into details about the slide itself. So excuse me for repeating a few slides, but it's on purpose. Okay. We talk about prefibrotic and overt myelofibrosis. We are not going to talk much about prefibrotic at all anymore. The questions were outstanding. I think we covered that pretty well. Let's focus on fibrotic myelofibrosis in much more detail because that's actually the bulk of the patients that we see. They come through the door often in a dying mode, not doing very well. A lot of different problems happen. What I perhaps would like to highlight here is that the leukemic transformation happens in about 20 to 25% of the patients. That is to say that as the single reason for death with myelofibrosis, yes, acute myeloid leukemia is the most common single reason, but overall 70-75% of the patients die from myelofibrosis itself, right? So that means bigger and bigger spleen, bigger and bigger liver, portal hypertension, pulmonary hypertension, lung failure, right heart failure. So slow death at home or hospice from multi-organ failure, that's the main reason for dying from MF itself. And then we do prognostication. I asked the question before, do we have a preference here? No, we don't. We are cognizant of a patient's overall survival, but do not project that to the patient itself because of the complexity of different prognostic scoring systems, moving one patient to the other group if you apply different prognostic scoring systems. And the other side of the coin is, as I mentioned before, the most important one, the donor. Is there a donor, and what type of transplant the patient is going to get? What are the comorbidities, overall performance status? So the application of these prognostic scoring systems is really relative, and we do not engage in patients in discussion of the survival based on these in much detail, but we emphasize that the disease might be aggressive enough to consider the transplant. And we certainly do account for the genetic complexity. Our standard practice is to do 81 gene panel, which includes a lot of different genes, and we would certainly include this in the prognostic scoring system. And we can do that online by MIPSS 70, but I can tell you what the actual application is. It is easy when you see the patients to pull the paper with IPSS or DIPSS scoring systems, DIPSS plus, and perhaps semi-intelligently assess that prognostication. In the groups of people who have low risk or intermediate 1 risk by IPSS, then the information on the genetic complexity adds a value. If the patient is already intermediate 2 and high risk by IPSS, hardly ever that you would be de-escalating that risk by application of the genetic complexity, right? You would say, oh, you are not genetically complicated, you are intermediate 2 by IPSS. I think you are actually low risk or intermediate 1 by MIPSS 70. So that hardly ever happen actually if you look at the data. So practically, we do the simpler prognostic scoring systems and then apply genetic information in those that are lower intermediate 1 by the standard IPSS, DIPSS. And then they go on to see the bone marrow transplant doctor and look at the risk of transplant itself. So that's the part on the transplant, and that's usually resolved quite often quickly. You confirm diagnosis, you do the prognostication in this way, where we say, yes, the disease has a potential for affecting your life. Within a few years, you should see the transplanter. Then the discussion focus on the transplant itself. Not really, I'm going to live 2.4 years or 3.5 or 4.1. That is unnecessary. That's my feeling. Then we move to look at what's wrong with the patient, right? Do we need to treat with medications? And there is a whole list of possibilities that we utilize in everyday practice. Depends on what patient suffers from. I like to point out a few things here. One is the assessment of the quality of life. We try to implement MPN-10 as the objective tool to get us information not only for purpose of prognostication, right? Some of these 10 questions that are listed here are part of the prognostication, right? But not all. And patients may have some other factors other than those that led them to live shorter. Problems with concentrations, abdominal discomfort, early satiety, fatigue. These are not prognostic factors. These are quality of life issues. And every time the patient comes through the door, first time around, I have dedicated nurse that collects that, and that gets into the patient's medical record. The problem is this is not in electronic form, and we cannot do this often. We do it as often as we can, let's say every 4 to 6 months. And if the patient is on a study, that's easy to do because there is a nurse assigned to the study. But otherwise, that is the problem of getting that information continuously, the lack of electronic record that would follow this particular item, quality of life, for us in an easy way. If we apply the quality of life questionnaire to patients that we see, then you will see that there are patients, even with a low risk or intermediate 1 risk, that are symptomatic, maybe not having those that are prognostically relevant. That's why I highlight that, but otherwise have bad quality of life. If you look in the left side, upper side, it says reduced quality of life based on prognostic risk. That is on the left upper corner, high risk, low risk. High risk patients are much more symptomatic, but the low risk patients may be symptomatic as well. And so we really encourage everybody to utilize the questionnaire to get some sense of a quality of life. And the criteria for initiation of the therapy then is being discussed. There are no real guidelines to say how bad the patient's quality of life needs to be for me to start therapy. We are doing one step at a time. We are trying to objectivize that quality of life with the questionnaire. A cutoff criteria of a worst single symptom being above 5 has been suggested. One single symptom above 5 out of 10, right, has been suggested to identify patients that should be treated to control that symptom. I think that's fair, and that's why we utilize this questionnaire to see how bad quality of life is and whether the quality of life issues interfere with the patient's performance overall. That's my next question. The FDA actually has opinion on when to treat patients with bad quality of life. They have defined that for us. This is interesting. This is a phase 3 registration trial underway around the globe. And if you look in the middle of the lower slide in the green color, this is a study that compares momelotinib, one of the JAK inhibitors, to danazol. This is a second line after ruxolitinib, comparing momelotinib to danazol. And the goal is to improve the symptoms and anemia. So how bad the symptoms needs to be to enroll? And the FDA says TSS of 10 or more. Imagine there's 10 questions. Each of them is from 0 to 10. So there are 100 points, right? The maximum will be 100. And the FDA agrees that if it's 10 or more, then that's bad enough for patients to go on an investigational study. So that's another clue when I'm asked how bad the symptoms needs to be. One symptom above 5 or totality of 10 or more. And then moving on, what does the ruxolitinib actually do? We all know that it decreases the big organs, very well known, very well seen on these photos. Also, you don't see the ribs here. From the left to right, patient was cachectic, he lost a lot of weight. On the right side, you don't see the ribs anymore. Patient gained weight, right? That's that quality of life improvements, weight gain, ability to walk, less of night sweating, low-grade fevers, less of itching, less of bone pain. So that's the symptomatic improvement. The key here on these photos actually is the time frame. And I'm going to talk about this quite a bit. I'm pretty aggressive about showing the results on timelines when and how to get to this type of response. Here it says after 2 months of therapy, saying that the benefit is really seen at the beginning and not much later. After 1 year of therapy, you're not going to get this type of response anymore. When do we use hydroxyurea? Our guidelines in the United States are quite clear based on a COMFORT-2 study. COMFORT-2 study, one of the 2 studies that led to approval of ruxolitinib, where in best available therapy arm, the control arm, most of people were on hydroxyurea. So ruxolitinib is preferred for symptoms in a spleen, and hydrea is usually used for high white cell count or high platelets, like in patients with prefibrotic myelofibrosis or patients that are transforming from ET or PV and have a high counts, they need the cytoreductive therapy. If you're talking about the symptomatic control or splenomegaly control, then the ruxolitinib is preferred. And then the timing of the introduction. Timing in sense of how sick the people need to be. I talk about how bad the symptoms need to be. Now I'm talking about the introduction of the timing in terms of the risk of dying. Unfortunately, many times around the globe in many countries, the patients need to be of certain risk of dying. And I alluded to that already in earlier talk, which we do disagree here in the United States. We, in our guidelines, do not combine risk of dying with introduction of any medications. That's tied to introduction of the transplant. Now, this is a study that you may have participated in, almost 2,500 patients of all types of risk of dying. And what you see here is the spleen response. You may have seen this before, but it's really important to emphasize that in the red color, patients with a low intermediate 1 risk that have a big spleen fared much better. This is over time, the spleen is always much better controlled in a lower risk group. Why is that? Because these people, these patients, get a higher starting dose of ruxolitinib. How can this be? Because they have less of anemia, less thrombocytopenia, and the management is much easier. You get them a better dose. The better dose is responsible for better spleen response. And if we analyze the studies with that particular question, what is the outcome of the patients based on risk of dying when it comes to application of ruxolitinib? You can see in the COMFORT studies, which were intermediate 2 and high risk patients, versus patients with intermediate 1 risk in other studies, and this is a nice comparison in a table. If you go with me from left to right, you will see that the spleen responses are better, the anemia is not as bad, the thrombocytopenia is not as bad, infections are less, and discontinuations are less. All because the patients are better in all the other aspects. There's less anemia, less thrombocytopenia, and they have a better chance to respond because the dose is higher. And that translates to something else. We are talking about the survival benefit. Survival benefit is on the label for use of ruxolitinib in the United States, not in many countries outside the United States. But when you have experience like this one, for example, and there is a 7-year difference between these 2 photos, you appreciate that that is a possibility. So on the left side, patient when came to us, and on the right side, 7 years later. So how do you get that? Why do you get that? Well, part of this is change in metabolism in the body. Albumin goes up rather rapidly. The cholesterol goes up, probably that's very well known, sometimes even too high. The body weight goes up. Performance status improves. In a phase 1 study, we even did a 6-minute walk test, which is the test to see about the activity, and it was markedly improved. So body composition, body function, everything is improving. And more recent information also suggests that the organ function improves. Now, we don't have anything like this for the lung function, although there are papers that suggest that the pulmonary hypertension decreases on ruxolitinib, which is interesting. This is an analysis of the kidney function, which is affected by the proliferation of myeloid cells in the kidney and inflammation as well. The kidney function appears to be improving on ruxolitinib. So better performance status, metabolism improvement, body composition improved, organ function improved, so people live longer with the good control of signs and symptoms. And if you look at analysis of the survival benefit by the risk of dying, and I'm trying to close the loop with when to intervene, you see here these are survival curves of the patients in the green lines exposed to ruxolitinib, and in blue lines are control patients that were either on nothing or on the best available therapy like Hydrea, and most of them crossed over to ruxolitinib. you see in the full lines, the top two lines on the right side, this is the survival of the patients with intermediate 2 risk disease. The dotted lines are survival of the high risk patients, suggesting that the patients with intermediate 2 have a better outcome, suggesting again to me, to tie to what I was saying before, earlier intervention may have a much better impact on the survival benefit of ruxolitinib over time. One factor will determine how long the patients live. One factor on therapy. On therapy, one factor has been shown, and this is the spleen response. Degree of a spleen response would be determining the longevity. This is our own experience, confirmed by many. Since then, in the green line, that's a survival probability. In green line, by palpation, 50% or more spleen reduction. In the light blue, less than a quarter spleen reduction by palpation. I'm not utilizing in everyday practice any fancy stuff like ultrasound, CAT scan, or MRI. Palpation and the tape, a questionnaire if I can to assess the quality of life, and the CBC, old-fashioned monitoring. We don't do bone marrow biopsies, by the way, to see about bone marrow change. We don't do genetics. I already talked about it. It is really palpation. It is CBC with differential chemistry and talking to patient about quality of life. Analysis of this type of a correlation has been done in many other studies. As I mentioned, this is the summary of analysis in comfort studies. This is very powerful to me. Each 10% reduction from baseline in spleen length. This was done by MRI, right? But it's still, each 10% reduction in spleen length was associated with a 9% reduction in risk of death. So it is important to optimize the therapy to decrease the spleen as much as possible. This was done also and analyzed in Italy. This is 284 cases from community setting in Italy. In the left side, overall survival with spleen response at 6 months. And again, 6 months, everything happens at the beginning, not much later. You see the overall survival is improved and durability of the response is improved by the reduction in the spleen. Which factors in this particular study affected the ability to control the spleen? They are listed at the top, at the bottom. More advanced condition, very, very high spleen, very high white cell count, delaying the therapy, and the dose. And the dose is one that I like to emphasize quite a bit because it's really up to the doctor to decide which dose, right? The timing is of essence. Earlier, I think I made that point clear, but then the dose is another one that perhaps is not quite clear. And the correlation between the dose and the spleen response has been shown again in multiple studies. This is the Comfort 1 study. On the left side, there is analysis after 6 weeks of therapy between the dose and the spleen response. The better the dose, the better the spleen response. On the right side is the correlation between the dose and symptomatic control. 10 milligrams twice a day in a dark blue is good enough to have a maximum benefit on the symptomatic control. That's a good and bad. The good part is, yes, 10 is excellent, right? So you don't need more than 10 to control the symptoms. If you treat patients only for the symptoms, then 10 is the starting dose and you don't worry about it much. The bad part is that many colleagues here in the United States try to start with a lower dose to avoid any myelosuppression or avoid any need for dose adjustments, and 10 is preferred starting dose. And what happens? People stay at 10. They have outstanding quality of life improvements, but the spleen does not respond very well. And everything that I said so far points to the fact that the higher dose, the better the spleen response and the better the survival of the patient. So my point here is at the bottom, avoid starting with low dose. If you do start a low dose for some reason, then escalate to the maximum safe dose quickly, every month or every 2 months. And by the way, this is how it's done for patients with low platelets, right? You start with 5 twice a day, then you go to 10, then you go to 15. That's what the guidelines are, how to treat patients with low platelets. That should be applicable to any other situations if there is any concern and you start with the lower dose. Why are we starting with lower dose? Many start because of worry about the anemia, which is fine. It is something that we know happens. This is analysis of the platelets numbers over time in ruxolitinib patients on the left. On the right is the hemoglobin. It does drop, but see what happens then. It bounces back. Now, why does it bounce back? There are several possibilities. One, the dose adjustments. Okay, dose adjustments is fine if there is a really terrible decrease in red blood cell count. But my take is that not every patient requires those adjustments, and the rebound happens even without those adjustments. We actually published a paper on that the rebound in red blood cells happens even without those adjustments. Plus, I would add anemia drug, erythropoietin, if the erythropoietin level is less than 125, danazol 200 milligrams twice a day, thalidomide perhaps 50 milligrams a day. I'll mention these later on. Again, so anemia drug in combination with the JAK inhibitor is what is also suggested by our NCCN guidelines in the United States. Be sensitive to the need for spleen reduction and don't start with low or reduce the dose automatically if there is some decrease in blood cell count. Let it be for a little bit. The things may actually improve with your management style, and the better the dose of ruxolitinib, the better the spleen response. So if there is one paper that I would like you to perhaps remember, or one slide from what I have said so far, this is the one. This is another amazing paper from Italy, Dr. Palandri, in 400 patients that summarized everything I said so far with data that supports it. It's not a review article, it's original paper. Number one, the influence of disease stage on quality of response basically start early. And number two, the influence of ruxolitinib dose basically start with the high dose and maintain high if it's safe in your clinical practice. Remember, there are guidance how to do it. Guidance are to be a guidance, not the rules that you have to act immediately if the things a little bit change and patient is otherwise fine. So look up this paper, it gives you all together. So my tips are here. Integrated for splenomegaly or myelofibrosis when it comes to ruxolitinib, regardless of risk of dying. We talk about anemia, underdosing, prophylactic underdosing should be avoided. I aim for maximum tolerated dose right from the beginning. I follow as per label, the starting dose, but then I am less sensitive about dropping red blood cell count or platelets because these are guidelines, and I feel comfortable having patients at, let's say, 80,000 platelets and patient is at 50 milligrams twice a day, and the 50 is providing excellent response in spleen and symptoms, and patients live at 50,000 platelets. I don't automatically reduce. That's just an example. Depends on the case. So I try to get a maximum dose going. The bottom of the slides is looking at some other issues that I did not talk much about it, but they need to be mentioned. Do not stop the therapy in patients that are responding unless it's absolutely necessary. Then give some steroids to counteract the rebound in the symptoms. Or if you really need to stop, taper it off. A possibility exists of opportunistic infections that doesn't come in percentages, except for a herpetic infection, about 5%. Usually we treat through, unless it's extraordinary case of a reactivation of TB or hepatitis B. Otherwise, we treat through and monitor for skin cancer that has been shown to be increased in people who were previously exposed to JAK inhibitor when they were living with Polycythemia Vera. So in that setting, I have a patients look at the skin cancer. The issue of the lymphoma as a possibility, lymphoma being increased in patients on JAK inhibitor has been resolved. There were 3 papers over last year saying that that risk does not really exist, and I'm not worried in my own practice about increasing risk of lymphoma in patients with myelofibrosis on ruxolitinib. We transplant patients while they're on ruxolitinib. I already mentioned that. That is standard practice for us to enhance enrollment in the transplant trials, particularly when the patients are responding particularly when the patients are responding well to ruxolitinib, or while they're in a losing mode, not when they completely lose all the benefits. If we see slow anemia development or thrombocytopenia development or spleen slowly comes back, then we are telling patients, don't wait for complete loss of response, go to the transplant now. So this is parallel process, teaching patients about durability of the ruxolitinib therapy. It's not going to work forever. We can optimize it to work very, very long period of time, but we always emphasize the need for the transplant if it's possible. After ruxolitinib, outcome is very poor. This is one of our papers. I showed this before. What can you do after ruxolitinib? Another study, or it's at the bottom of the slide, re-challenge with ruxolitinib. Re-challenge after 4 or 6 weeks. You kind of reset the sensitivity of the cells to ruxolitinib in many cases. That has been published by our colleagues in Cleveland Clinic as a possibility, and you have a chance not only to do this once, but even twice. This is the reference number 3 in this slide. I hope we can share the slides with you. Published in 2018. So re-challenging with ruxolitinib is a possibility. What do we do if patients progress with the blasts? This is one slide. In the middle of the slides, you have MFAP, peripheral blast 10 to 19, and MFBP or AML. This is the blast 20% or more. What you can appreciate here that we don't wait. We do not wait for patients to get to acute myeloid leukemia. The therapy for patients with accelerated phase, 10% to 19 and 20 plus is the same. Why is that? Because the outcome is so poor. Median survival of AP phase is about 18 months. Median survival of blastic phase is 6 to 9 months. We intervene early, and we intervene, as you see on the right side, with hypomethylation agents, according to our guidelines as a preferred mode of action, which keeps the patient outpatient. It's not intensive. Patients can be seen in outpatients, and you give it for a few months, 2 to 3 months, to see whether the blasts can be controlled. If the blasts are controlled, that means less than 10%. That means also the disease is sensitive to therapy. Then the transplant can happen if there is a transplant candidate. If you need, you can use intensive induction chemotherapy to get the patient to transplant. But otherwise, if there is no transplant, we continue with hypomethylation agents or low-intensity induction chemotherapy, which for practical purposes is a cladribine with the low-dose RSC. Cladribine for 5 days and 10 days of sub-Q RSC. Most of the time, we do this in outpatient setting if we need chemotherapy to maintain patients or get them a little bit better when they're in accelerated or blastic phase. Even in this setting, we utilize ruxolitinib for control of the symptoms, 10 milligrams twice a day, as I mentioned before, 10 milligrams twice a day without those interruptions of modifications, because the blood count will be changed due to hypomethylation agents of chemotherapy. And then I leave you again with the myelofibrosis part with another photo. Patients brought to me on the way to hospice, 2010. She had 40 kilos. We had to hospitalize her because you can obviously see what's going on. There is a large ulcer on the leg due to high-dose hydroxyurea, which was given to control very big spleen and very big liver. And if you do a good job, this is what happens. So I like all my patients to live like this for much, much longer, not only 3 months. This lady died, unfortunately, after 8 years from unrelated medical condition, but the disease was controlled very well, and she was able to walk again and enjoy life fully. So let's aim to optimize the therapy at the beginning to get them to live that long. We have a little time for Polycythemia Vera. This is less complicated. Here we have a table that summarizes it all. In the upper part is the risk assessment, which I mentioned before, age or history of thrombosis. Remember, the platelet number is not the risk factor. There are situations, even in a low-risk situations, where cytoreductive therapy is necessary. That is in the middle of the slide. So high-risk patients and some low-risk patients may require cytoreductive therapy. Again, progressive leukocytosis comes to mind, where the white cell count goes up exponentially. There is no particular number to say. That's why the guidelines are a little bit mute on the numbers, except for the platelets. Platelets above 1.5 million are associated with the risk of bleeding, as I explained before, but otherwise, the leukocytosis, what number to give you, I can't really give you the number. That's still in the discussion. Once we start therapy with cytoreductive therapy, the guidelines usually suggest not to only focus on the hematocrit control, which is number 1, but also to control the platelets, white cell, spleen, and symptoms. And I understand the control of the spleen and symptoms would be quality of life issues. Control of the white blood cell count would be good because the white cell count has been associated in many papers with the increased risk of thrombosis. The weakest of the 5 factors is the control of the platelets because the platelet number has not been associated with the risk of thrombosis. Now, when we talk about control of hematocrit, it says without phlebotomy, right? The guidance would say without phlebotomy. This is now a contentious issue. Our Spanish colleagues said that if you are treating patients with hydroxyurea and you still need 3 or more phlebotomies a year, you still need phlebotomies while you are treating patients with hydroxyurea, 3 or more, that's not good enough. It needs to be less than 3 a year to decrease that thrombotic risk. Our Italian colleagues say that may not be the case, so that's open to debate. In our own practice, once we start cytoreductive therapy, we try to eliminate need for phlebotomy. We really follow what the guidelines would suggest we do. The quality of life issue with PV patients is coming to forefront with the application of that questionnaire. The same questionnaire that we utilize for MF, we utilize for PV or ET, and you will be surprised. If you just enter the room and say, how are you doing? They say, I'm fine. Well, if you ask the questions, they're not really fine. They have a lot of different problems, and the quality of life issue is an issue in PV as well. Once we try hydroxyurea, which is standard practice in almost all cases, 90% of patients would be given hydroxyurea. Only a small proportion would be given interferon if they're very young and need cytoreductive therapy. Then we have guidelines which were developed, as we all know, for application in the clinical studies to say that you still need phlebotomy. This is in the blue box. If you need still phlebotomy, or you still have high platelets or white cells, or the spleen did not reduce at least for 50% of time, after a good amount of time and a good dose of hydroxyurea, that's a resistance. And then you have intolerance in the lower part of the slide. This may or may not be something to consider for every practice. We try to consider that. I would like patients not to have phlebotomy anymore and to reduce the spleen and normalize the white cell count, as I said before, at the maximum dose that I find safe in that patients. Practically, really, we up the dose with Hydrea to achieve the goals, and what happens is toxicity. Usually it is the toxicity that limits the maximum dose given to control the numbers, right? So you have cytopenias or the mucocutaneous ulcers that prevent you from going up to control this blood cell count. By chance, I would say, with this application of these definitions of resistance or intolerance, we actually identify a patients that have a worse outcome. Not only that they have a bad quality of life or uncontrolled myeloproliferation, they have a shorter survival and a high risk of disease evolution. And survival is shorter many times because of uncontrolled blood cell count, leading to the thrombotic risk, right? So the goal in the second line is the same, knowing that they have more aggressive disease and more transformation risk and shorter survival. So interferon is being developed in Europe. It was recently approved for PV. I'll mention this later. It has advantage of being not chemotherapy agent, so we utilize it in younger people, usually younger than 40. You can say younger than 50 these days. It has a possibility of causing some other benefits, but most of them, as you can see on this slide, have a question mark. So none of these are proven in any possible randomized study that there is a real advantage over chemotherapy, for example, in older patients, and that we can say that there is a real prevention of a progression to myelofibrosis or AML, or elimination of the disease by virtue of eliminating JAK2 clone. That can happen in 10 to 15% of the patients, but we don't say that the disease is gone if I cannot detect the JAK2 mutation. This is evidenced in one of the studies. There are several studies that show that on the left side, about 3/4 of the patients or 80% of the patients in some other studies have a complete hematological response, which is the goal of therapy. And on the right side is the decreased injectable allele burden, which is not the goal of the therapy. One needs to dissociate what the actual benefit is. Control of the blood cell count decreases the thrombotic risk. We all believe that. Decrease in injectable allele burden, or even eliminating it in some patients, has not been shown to be clinically relevant at this time as of yet. So we focus on the blood cell count, not genetic testing. And over time, you lose that response, particularly because of the toxicity. This was our own experience with pegylated interferon Pegasus. We lose about 5 to 10% of patients every year, mostly because of low-grade toxicity. depression, autoimmune problems, cytopenias. And after 5 years, only half of the patients are still on therapy. So you cannot really give it forever. And in terms of the molecular response, this is in the red box, only complete molecular responses that are few appears to be durable, and again, not clinically relevant, because even then you may have still disease active. But the information is on molecular response out in the public domain, and many patients wonder about it. I always tell them that this is in investigational part, and we don't judge the utility of interference based on the molecular response. Ruxolitinib is approved in a second-line setting, as we all know, comparison to best available therapy after Hydrea, which was most of the time Hydrea itself, because there was not much else that people were doing. There are occasional patients with interferon in that group, not many. In that setting, comparing to best available therapy, in the lower side of the slide, you see in a yellow box all the benefits: control of the red blood cells, white cells, platelets, spleen, and symptoms. And number 5 in a box, it's a fewer thrombotic events, which comes from the safety analysis. And I'll show you this in a second. There were 2 studies, actually, perhaps not very well known, that analyzed the utility of ruxolitinib in a second-line setting. The Response 2 study, which is featured in the middle of the slide, is in the same setting of a second line in people without the splenomegaly, comparing to a Response study that is widely known and led to approval of ruxolitinib, where everybody had to have a big spleen. The result in control of hematocrit and the complete hematological response and control of the symptoms is identical or about the same in the 2 studies. This is to say that presence of a big spleen is not mandatory to be present for ruxolitinib to control the blood cell count and control the symptoms, or to be prescribed in the first place. How long does the benefit last? This was just published in Lancet Hematology about 3 weeks ago. It was a poster at ASH. If you have a response, the response is very durable. About 75% of the patients will be still responding after 5 years of therapy. So much, much longer than in the setting of myelofibrosis. This is durability of complete hematological response. Majority of people after 5 years are still responding, controlling all 3 cell lines. This is something practically important. It was published, perhaps not very well known, that the iron deficiency, without giving in the iron deficiency resolves in most of the patients on ruxolitinib. This is seen by looking at MCV on left side. Between the gray areas is a normal range. In the green line are patients treated with ruxolitinib. So MCV improves. In the middle, it's iron improves. And on the right side, it's ferritin. Ferritin improves without giving the iron. We don't really know why and how, but it may be beneficial in some patients that have side effects from iron deficiency when treated with hydroxyurea. What are the side effects, long-term side effects? At the top, anemia, thrombocytopenia, very rare. The starting dose in PV is 10 milligrams twice a day. 60% needs more, and only 10% needs less because of anemia, thrombocytopenia. And then herpetic infections are already showed 5% as in myelofibrosis. Secondary cancers, the only one here that I want to say a word about is non-melanoma skin cancer, the second bullet, which I already mentioned before. The secondary cancers in PV setting in patients with precancerous lesions or cancerous lesions while they were on hydroxyurea, that appears to be increased, and I send those patients to the skin doctor for surveillance every 6 to 12 months. And thrombotic events. Thrombotic events as a feature of safety analysis in the red box. You can see, despite the exposure time to ruxolitinib being much, much longer than the BAT, the number of events is fewer, considerably fewer, which makes sense. You control the blood cell count, you decrease the thrombotic events. No p-values here because it's a safety analysis, so you can't say anything about superiority. It's just the information that is useful. In conclusion, so Hydrea is considered frontline. Resistance intolerance does happen in about 20% of patients. Interferon is a good option, but it cannot be given forever. Median 5 years in studies so far, which is a shame. I like interferon for my younger patients quite a bit, but otherwise in common practice, we use ruxolitinib, which is really good in improving quality of life, very good also in controlling the blood cell count, and you can give it, as you can see, for a very long period of time. So I thank you very much for this part.
We have, hay tiempo para algunas preguntas. Ahí viene una pregunta.
I can't hear.
Now?
Yes.
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 How do you manage patients with myelofibrosis with low-risk disease who have high-risk mutations?
Okay. Outstanding question, and it does really bring that group of patients to forefront, because in that setting, management of the patients in terms of management of anemia or symptoms or a big spleen is unnecessary, by meaning a low risk. They usually are asymptomatic, younger, and they don't have clinical reasons for medical therapy. The issue is referral to a transplant because they have a bad genetics. And we struggle with that because we know that bad genetics will expedite their progression of the disease. And you would say, I would transplant patient now when there is nothing really wrong, just bad genetics, and the outcome of the transplant will be better. However, the genetic information is not absolute. That means that it's not going to inform you that the patient will be dead in a year or two. It's one of the factors that tells you that the patients will have a more aggressive disease. And we usually wait. We usually wait for the signs of a progression, clinical progression. The anemia develops or the spleen starts to grow, and patient actually may move from low to intermediate 1 by having systemic symptoms or hemoglobin less than 10, or you see some blasts. So you see clinical evidence of a progression. Then it's much easier for everybody to say, yes, this genetic information is affecting you, disease is changing, and patient is informed or educated about this in advance. And then we go to the transplant when the clinical reasons follow the genetic reasons.
Thank you.
There's another question. Oh, no.
Thank you for the presentation. I want to know what is your usual practice in a patient who comes with symptoms, splenomegaly, and severe anemia.
So the question is what to do with the patients that have symptoms and severe anemia. And I didn't understand, they have low platelets. Was that the question?
No, just anemia, perhaps a lot of
just
symptoms,
anemia.
splenomegaly, but severe anemia as well.
Okay, yeah, that is quite common, right? That's quite common. And that leads many to utilize the Ruxolitinib at a much lower dose because the anemia may worsen, right? 50-50 chance to worsen the anemia. Now, what we would do, we would still follow the prescription pattern for Ruxolitinib based on the platelet number and add anemia drug at the same time. First of all, the chance of anemia getting worse is 50-50. It's not given. It's not like 100% I will get anemia worse. It's 50-50 chance, right? So I count on 50% not to happen. And I add anemia drug at the same time, danazole or erythropoietin if it's low, or thalidomide, and I'll mention this later, to improve the anemia and get the Ruxolitinib to work better. So I would start that patients if the platelets are 250 at 20 milligrams twice a day, and watch for anemia, transfuse if necessary, and try to get them to be on a higher dose for first 3-4 months, counting for that to work on the spleen, maybe transfuse more often, and not cut the dose right away. to get that spleen under control, for that benefit to last much longer.
Another question. Nowadays, is there any role of thalidomide, lenalidomide plus prednisone in the treatment of a patient with myelofibrosis?
Yes, absolutely, yes. One factor which I'm going to talk later when we talk about ASH update is adding thalidomide to ruxolitinib, but on its own, the thalidomide with prednisone or lenalidomide with prednisone are, in my view, best available therapy after JAK inhibitors. So just last week, I had a patient with a big spleen, 73-year-old, transfusion requiring for red blood cells and platelets, very advanced case. I cannot give them the ruxolitinib because platelets were 23. And so I can take the spleen out, but she is not the surgical candidate. That will be my preferred way. This is an indication for splenectomy. Very low blood cell count, inability to give any medications, right? Then after splenectomy, the count goes up. Then I can use JAK inhibitor to control the liver and improve the quality of life and make them enjoy life fully. But in this case, not a surgical candidate, I give the lady thalidomide and prednisone, right? Because that may have a potential to improve the red blood cells, maybe platelets, spleen to some degree. That's, in my view, the best available therapy.
Okay.
Yes, thank you, doctor, for excellent conference. What about the association of interferon with ruxolitinib?
Okay, very good question. There are studies, as you know. I think this is why the question comes handy. And there is even publication from Denmark on the possible combination of interferon with ruxolitinib. In that particular publication from Dr. Hasselbach, majority of the patients were Polycythemia Vera patients or proliferative early stage myelofibrosis. And it was difficult to see whether the combination of the two provide more benefit than one alone. The idea here is to utilize the JAK inhibitors to counteract the symptoms that interferon may cause, deliver the two medications safely together and enhance the benefit, and to provide anti-inflammatory benefit from the JAK inhibitor as well. All of this combined together. The clinical benefit in the paper so far was not such a striking to say that we should be doing this as routine. Quite contrary, people were disappointed. But there are other studies underway where in France, for example, that was already presented at the meetings, they are trying to devise the best way to deliver it in patients with advanced myelofibrosis rather than in early proliferative, where the interferon may have some benefit biologically as well. So to say then this is evolving field. We do not utilize this off-label at all in everyday practice. That is really a subject of clinical studies.
Okay. We have three questions. Laura, Miguel, and Juan.
Yo tengo abierto.
Laura.
Bueno, muy interesante su presentación. Yo quisiera preguntarle si en la era de ruxolitinib la esplenectomía tiene algún rol en la mielofibrosis.
Excellent. So splenectomy, yes, the splenectomy still has a role. One example is what I mentioned as an answer to previous question. Patient comes, has a very big spleen, and the blood cell count is very low, particularly the platelets. And the platelets prevent me from giving a patient very good JAK2 inhibitor dose. Then I would consider splenectomy to improve the blood cell count, which is expected. And only then, the next day, when the blood cell count shoots up, I can give patients very good dose of ruxolitinib to counteract the liver or prevent worsening and improve the performance status and weight. This is one that is relatively easy to understand, but it's not done very often. We check we catch patients earlier on, not in such a bad shape anymore. The second indication is on therapy. You have patients on Ruxolitinib and they're doing well. After, let's say, 9 months or 12 months, the spleen starts to growing back. The patient still feels much better. They have 5 kilos or 10 kilos more. They enjoy life, no symptoms. And the spleen is continuously growing and as big as it was at the beginning. And it's causing to cause problems in the belly. I had 3 cases so far when we did the splenectomy and maintain patients on the Ruxolitinib for quality of life improvements. So that's another possibility. We do not do, by the way, we do not do the splenectomies before the transplant anymore. I don't have the actual results, but for last 6 or 7 years, we do not do this anymore. We did not show the benefit. There are always exceptions when it's extraordinarily large, but then it's a judgment call of the transplant doctor. As a general rule, we don't do this anymore. So again, so indications, low blood cell count, either before or after therapy is the primary reason for splenectomy. And we prefer this over radiation. Radiation is really the last resort, like palliation in a way.
Está Miguel, después Juan y después el doctor Muso. En ese orden hacemos.
Yes, if you have a patient with myelofibrosis treated with ruxolitinib, and the patient has MGAS growing up or secondary neoplasia, what do? You continue with the same dose of Ruxo?
Yes, and we treat the other problem if the other problem needs to be treated.
Well, supposing, moving to Polycythemia Vera, supposing that the symptom is intractable pruritus, which is your best stepwise after cytoreduction, phlebotomy, hydroxyurea, even interferon?
Okay, if the patient is on cytoreductive therapy, let's say hydroxyurea, and has, despite the good control of the blood cell count, a terrible quality of life, itching, like you say, it's so bad, you would then try perhaps to give the aspirin twice a day, try some antihistamines. We all do the same, right? Antihistamines, some medications that are typically used for anxiety or depression, like Paxil. Try to counteract that quality of life issue by adding relatively benign supportive care measurements. In real life, if you really have such a bad quality of life and itching is problematic, the patient cannot function, then that is one of the reasons why to change to Ruxolitinib. The 9 out of 10 patients on Ruxolitinib eliminate itching. That is not common reason for a change. I would say maybe 2 or 3 cases in my practice where the itching was the primary reason for referral, despite having good control of blood cell count, and after a change, the itching resolves. So apart from changing to Ruxolitinib, other supportive care measurements have not really changed and have not improved over last decades.
Sir, in patients with P. Vera, to achieve complete molecular remission, would you consider withdrawing therapy, or in case you do not, for how long will you continue treatment?
Excellent. Excellent. You must have a large group of patients on interferon. How many do you have?
Well, I have several. For many years, I've been working with it by now.
Okay. So first of all, we were saying earlier on that the number of patients that have a complete molecular response, which needs to be confirmed, by the way, by the allele-specific PCR with the sensitivity of 0.1%. NGS usually has sensitivity of 3 or 5%. So the test is important, right? If you really have by PCR molecular remission, which is not very common, 10 to 15% of the patients, then you can ask that question. This is a really good question. right? You may say that we can borrow the experience from CML and say after a year, 2 or 3 years, let's say 3 years of being in complete molecular response, you should stop, right? You do these days NGS and you look for other mutations. There is always the possibility of developing other clones. That has been published. While you are on interferon, that patients develop other clones as well. That is possibly reflective in the notion that even though in patients who have complete molecular response by virtue of eliminating JAK2 clone, there is still a presence of the disease. The bone marrow is still abnormal. They are still at the risk of a thrombosis or progression, even though they don't have a JAK2 mutation. That has been published 2 years ago, Lancet Hematology. But the question is really intriguing. So Dr. Khilajian has analyzed his own patients in terms of what happens when you stop. And in his case, majority of the patients, these are younger females, frontline mostly. Most of people stopped because of inconvenience, and why would you continue? Everything is fine. In this case, the degree of the molecular response, like we do for CML, appears to have a significance. If you are at molecular level of MRI -3 or -5, like for CML, then the chance of relapse is negligent. But this is really pioneer work in a very small number of patients. So we do not at this point in time advocate stopping. We are following these patients, and we here at MD Anderson, we'd like to do molecular testing and the bone marrow testing as a part of the study every year, and to address this question, but also to address the question of a loss of response. We have patients that were responding very well, and after 4, 5, 6 years, they're starting to lose response. We don't have an understanding why interferon doesn't work anymore. So it's a evolving field, not for practice yet.
Thank you.
Hacemos una última, last question. And
Thank you. You emphasize on the early start of Ruxolitinib in MF. I find it really difficult in daily practice to start Ruxo only for symptoms. Do you base your decision on those 5 or 10 score? I find it, I am not so convinced with that utility of the MPN 10 in this situation, only for symptom control. Here we have the issue of drug cost in Argentina, and we really have to be convinced about the indication. What is your opinion in daily practice?
This is a really good question, although it does not apply to so many patients, but it's very important for a fraction of the patients. They may not have a big spleen at all, but they have a bad quality of life. And because we understand that living with bad quality of life is not satisfactory to anybody, us as the doctors or the patients, we want to do something. And then the issue of how bad the symptoms needs to be, or what is the cost of the medications that I want to give it to you for the quality of life improvement, comes into play. And unfortunately, the cost is the one that disturbs me the most, because I know it works, right? And I know the patients feel so much better in a month, even though they perhaps do not know that their life is so bad. Once they get better, they say, wow, that's such a change. And that happens within 4 to 6 weeks. Why am I talking about these cutoffs of 5 or more, or a total of 10 or more? Because that is a question that comes handy all the time. That's what you are asking, actually, how bad the symptom needs to be. And so the information is slowly coming up from this kind of a retrospective analysis or prospective studies. Not to say that, oh, yes, you have to utilize that, but these are just some of the possible guidelines ways to consider it and to have some justification. Hey, the FDA says so. Hey, the studies show this is something that can support your claim for prescription. That's all it is.
Okay, thank you. So there's no more questions. Perhaps we will make a break, 15 minutes break, and then continue with clinical cases. Okay, Serge?
Excellent. Thank you so much.
Bueno, vamos a seguir la jornada. Bueno, hay gente abajo, pero por ahí si esperamos a que suban todos se va a demorar bastante, ¿no? Sí. Sí, los colores cambiaron al pasarlo desde el pendrive. No creo que hayas elegido azul oscuro y negro, ¿no? No, pasa. Pero quiero esperar, pero pasa, quiero esperar a que esté Verstovsek conectado. Pero si querés, mira. Y para pasar con esto. ¿Sí? Bueno, a ver, por ahí hacemos silencio, así podemos empezar con los casos clínicos. Tenemos 4 casos que van a ser presentados por el médico que sigue al paciente. Y bueno, el doctor Verstovsek está conectado, así que él está escuchando. Va a haber traducción simultánea para él, se puede presentar en castellano.
Buenísimo.
Y el primer caso lo va a presentar la doctora Mari, que ya está trabajando en Mercedes, y es sobre un paciente con mielofibrosis.
Buenas tardes. Bueno, ya me presentó Fede.
Make it a little louder. I can't hear very well.
Did you hear me, Federico, or?
A little louder, please.
Okay, un poquito más fuerte, dice.
Bien, ok. Buenas tardes. Traigo este caso clínico que en realidad es una paciente que estoy viendo en Mercedes, en el hospital, Mercedes, provincia de Buenos Aires. De una señora, una paciente de 79 años de edad, que consulta, o sea, ella ya tenía diagnosticado en otro centro una Polycythemia Vera. Concurre a la consulta como una segunda opinión en enero del 2019, con pérdida de peso de más de 10 kilos, y él me trae una biopsia de médula ósea que había realizado, evaluada en otro centro, del 15 de marzo del 2010. La biopsia de médula ósea, bueno, tenía 80% de celularidad con megacarocitos presentes y tenía, digamos, a nivel molecular un JAK2 positivo, BCR-ABL negativo y venía tomando ella ya desde el diagnóstico hidroxurea, que en ese momento estaba tomando ella un comprimido por día. Después de haber variado, digamos, ella me refería que había estado, digamos, con dosis, digamos, variadas durante el tratamiento. Y el 23 de enero del 19 yo le repito, le hago un análisis donde ella me trae un hematocrit de 34 con hemoglobina de 11, glóbulos blancos de 50.600, con desviación a la izquierda, 77% de polimorfos, no tenía blastos en sangre periférica, plaquetas 155.000, una LDH de 1.672, por lo cual yo me planteé hacerle una nueva biopsia de médula y evaluar con un ultrasonido el vaso. Bueno, esta es la imagen de la biopsia de médula del 2010, donde estaba diagnosticada con Polycythemia Vera, donde era una médula ósea hipercelular y en lo que se muestra, y bueno, una mayor descripción la puede hacer el patólogo, si quieren participar. Esta es la biopsia del 2019, también hipercelular. Y bueno, eso era como un resumen. Retomo de donde había quedado, que la señora, le repito, el eco abdominal, Me trae los resultados el 21 de marzo y tenía una esplenomegalia de 18 y la biopsia, el resultado de la nueva biopsia evaluada, también 80% de celularidad y informaban una mielofibrosis tipo 2. Repito, también molecular, JAK y BCR-ABL, queda positivo el JAK y un BCR-ABL negativo. El score del IPC se le daba de 3. El 25 de marzo, repito un análisis donde tiene hematocrito de 23, 7.9 de hemoglobina, glóbulos blancos de 19.400, plaquetas de 83.000, por lo cual suspendo la hidroxurea y empiezo el tratamiento con Ruxolitinib, que la dosis le inicié con 15 miligramos 2 veces por día. El 24 de abril concurre de nuevo al control, ya tratada con Ruxo, con un hematocrito de 25, con 8,7 de hemoglobina, unos blancos de 34.600, también con ligera desviación a la izquierda, 62%, sin blastos, plaqueta 123.000. Como persistía con tanta anemia, decidí empezarle eritropoyetina, 4.000 unidades, 3 aplicaciones semanales. Mantuve el Ruxo a 15 miligramos 2 veces por día y a las 3 semanas la señora concurre a la consulta porque estaba con hematomas generalizados, con lo cual en ese momento le pedí urgente un laboratorio y el recuento plaquetario le dio de 30.000 plaquetas. Entonces, en base a ese recuento, le disminuí la dosis de Ruxo a 15 miligramos por día, pero me llamaba la atención que persistía con leucocitosis. En diciembre del mismo año, del 2019, le hago el control de los valores y mejoró con la eritropoyetina la anemia con 37 de hematocrito, 12 de hemoglobina, persistía todavía con leucocitosis 23.600, plaquetas de 55.000, un LDH de 1.900, con lo cual le decidí agregar la hidroxurea por estos glóbulos blancos que seguían elevados. Le repetí el eco abdominal, tenía un vaso de 16, o sea que hubo algo de respuesta con el Ruxo, y en enero del 2020 concurre con un nuevo análisis de control con un hemograma prácticamente normal. Hematocrito 39, hemoglobina de 12, glóbulos blancos de 12.300, con 54% de polimorfos, no había blastos en sangre, plaqueta de 132.000 y un LDH de 1.300. Y en base a este caso, bueno, mis dudas eran, que me planteé en ese momento era, esta paciente con múltiple terapia, o sea, mantener este tratamiento, ¿hasta cuándo sería? Que eso sería una de las dudas que tengo, porque la señora está politratada y no sé, digamos, hasta cuándo podría mantenerle ese tratamiento. También es que está un poco intolerante al Ruxolitinib porque bajaron las plaquetas y las sostiene hasta el día de hoy. Casualmente la semana pasada la volví a evaluar y tenía 60.000 plaquetas que volvieron a bajar respecto a las de diciembre. Y otra duda que me planteé es el riesgo de progresión a leucemia, ya que tiene una exposición muy prolongada con hidroxurea, y si también se podría considerar a la LDH como un factor adverso, un factor pronóstico, digamos, adverso. Bueno, muchas gracias.
Gracias, Lilia. Okay, Serge, would you like to comment on this case based on these questions or whatever you want to say?
Can you hear me well?
Yes.
Okay. So thank you very much for an interesting case. There are quite a few bits and pieces here that we can talk about in general, perhaps not only about the case itself, but in general. So the patient progressed from PV to myelofibrosis, no problem with that. Anemia, high white cell count, high LDH, fibrosis, increased spleen. The Ruxolitinib was started instead of hydroxyurea, and it caused thrombocytopenia. My suggestion usually is to decrease the dose of ruxolitinib in a way that you maintain giving it twice a day. Let's say from 50 milligrams twice a day to 10 twice a day or 5 twice a day, because the half-life of the drug is 3.5 hours. And once a day rarely works. It may, but in phase 1 study, we studied once a day, and twice a day is better. So perhaps from 15 daily to go to 5 twice a day if the platelets are still low. That's something for other patients that may be useful. When we start with ruxolitinib and patients already anemic, the question was earlier on management in these cases. My own practice would be to start together with anemia drug. You added the anemia drug erythropoietin level, erythropoietin injections a little bit later, which is fine. I see that ferritin was 146, but many patients that come from PV to MF are still iron deficient. And ferritin may be a little higher because it's inflammatory marker. The iron may be still low. I typically check the iron, and if the iron is low, I give the iron and erythropoietin together to improve the red blood cell count while giving ruxolitinib. The persistence of leukocytosis as a prognostic factor for bad outcome is something open to debate. If the therapy in general, not for this particular case, is able to control the signs and symptoms, but the patient still has a white cell count which is 25 or 45,000, and we have difficulty in finding anything to decrease it, I typically leave it that way. As long as the anemia is not too bad, the platelets are not too bad, meaning very low, the spleen is very well controlled, and symptoms are very well controlled. I understand the need for possible correction of the white blood cell count, but many times I am satisfied with patients having multiple benefits despite having white blood cell count above normal at 25 or 35,000, as long as it's stable. The shocking response is the last one, where you add hydroxyurea and everything normalized. Can explain that very well, but it's really very good for the patients. At that time, she did not have much benefit from ruxolitinib in general, maybe because it was given daily, maybe some other reasons, but she's good. The hydrea is working, and that's pretty good. If you go to specific questions that you have, the life expectancy in these people is shorter, as we all know, and exposure to different drug therapies in general in myelofibrosis area does not project the worst outcome, as long as we are able to find a therapy that would be controlling the disease signs and symptoms. This is, for example, unlike the situation in ET or PV, where chemotherapy after chemotherapy, hydroxyurea and then, let's say, busulfan or something like that, is known to increase the risk of acute myeloid leukemia 5 to 8 times. So in myelofibrosis, we are less worried about it because the life expectancy is much shorter, and there is no that time frame to get to perhaps to increase the risk of acute myeloid leukemia because of multiple therapies back to back. The persistent leukocytosis question, well, the disease is causing it, and it's typically tied to big spleen as well. And if it persists, I am less worried about it, as I suggested, as long as it's stable and the blasts are not very high, right? The blast is different topic than high white cell count. If the blasts go up, then hypomethylation agents are fine. The hydroxyurea exposure and association with acute leukemia is open to debate in people with ET and PV. In myelofibrosis, that is less of a worry because of aggressiveness of the disease itself. The LDH as a prognostic factor has been studied, but it loses its independence prognostic factor significance in the light of high white cell count over 25,000 or big spleen in some studies. So it is less of a value to monitor as indication of a response or a risk factor. Now, this is not to say that if the LDH goes from 1,500 to 5,000, then we should not say, why is that? That would certainly mean that there is much more robust growth of the cells and many more cells die, which would mean that we need to look for reasons why is that happening. And usually is associated with a rapid change in white cell count or a rapid increase in the blasts. But on its own, it's not usually prognostic factor. These are my comments.
Okay, thank you. Very nice comments. I think we can move on to the next case. Doctora Lucia Fuentes de Alexander Fleming will present her case. Lucía, pasa a la siguiente y aparece, creo, ¿no?
Hola, ¿qué tal? Mi nombre es Lucía Fuente, del Instituto Alexander Fleming. Voy a presentar el siguiente caso, que es una paciente de 52 años con un diagnóstico de Polycythemia Vera realizado 10 años antes en otro centro, donde fue seguida y recibió tratamiento con hidroxiurea y requería entre 1 y 2 flebotomías por año. En noviembre de 2019 ya consulta por fatiga progresiva, mucha astenia, algunos episodios aislados de fiebre y tenía además hematomas espontáneos y epistaxis. Consideramos que no tenía síntomas B, en realidad porque la paciente tuvo un episodio de fiebre aislada, que es lo que la lleva a consulta, pero que después no repite. En la ecografía tenía esplenomegalia de 16 centímetros, no tenía hepatomegalia. En el laboratorio encontramos que tenía un hematocrito de 23%, con hemoglobina de 7,4, 9.200 blancos, plaquetas en 12.000 y una LDH aumentada de 1.400. El aspirado de la médula ósea fue seco, se intentó en 2 o 3 oportunidades, no pudiéndose obtener una muestra representativa, y se hizo una citometría de sangre periférica donde se evidenciaron 4,3% de blastos mieloides, además de rasgos disемatopoyéticos en neutrófilos y muchos precursores eritroides en sangre periférica. La mutación JAK2 fue positiva y el citogenético de sangre periférica se obtuvo 47XX con un isocromosoma 8 en 2 metafases y en 4 metafases además tenía un marcador adicional del cromosoma 9 que tenía una alteración que no se pudo definir si era con el cromosoma 2 o 4 y en 4 metafases 46XX. Estas son las muestras de la patología que se las dejo a Anaí para que se las cuente.
Bueno, la celularidad está muy aumentada, 95%. Hay una predominantemente proliferación mieloide con desviación a izquierda, en algunos focos con características inmaduras, para señalar, con disminución de elementos eritroides y de megacariocitos y displásicos. La inmunohistoquímica, bueno, que la hicimos con distintos marcadores, no mostró un aumento de CD34. Acá vemos con mayor aumento, entonces, el aumento de... Bueno. El de arriba de todo. Acá vemos el aumento de los elementos mieloides con desviación a izquierda y en algunos sectores, algunos focos con algunos elementos menos maduros. El retículo, que lo vemos con menor y con mayor aumento, era un grado 3, una fibrosis grado 3. Y la inmunohistoquímica nos muestra el gran aumento de elementos mieloperoxidasa positivos con algunos aumentos de monocitos. CD34 no mostraba un aumento significativo tampoco, y el 117, que marca además algunas otras células un poco más, pero tampoco era un aumento tan importante. Entonces se plantean desde el punto de vista histológico las posibilidades de una mielodisplasia con fibrosis, versus una leucemia mieloide aguda. Y en este caso es difícil, si bien el aspecto histológico podía parecer el de una leucemia mieloide aguda, los blastos CD34, o digamos, las células CD34 positivas eran alrededor de menos de un 5%. Entonces eso, si bien sabemos que puede haber blastos CD34 negativos, este elemento no nos podía ayudar ni para confirmar ni para descartar. Creo que no.
Entonces nos encontramos frente a una paciente joven de 58 años con diagnóstico con antecedente de policitemia vera y un cuadro que impresiona una progresión rápida con citopenias severas y una anatomía patológica que no nos puede diferenciar entre estos dos cuadros. Entonces, considerando esto de que la inmunohistoquímica no puede realizar el diagnóstico de que es una leucemia aguda, le queríamos preguntar al doctor si le parece que el diagnóstico cuál de los dos le parece el diagnóstico más apropiado y si en el caso de que un estudio de NGS nos podría ayudar a definir el diagnóstico y también incluso definir un posible tratamiento y qué tratamiento nos sugiere en esta paciente de tan difícil diagnóstico definitivo.
Ok, gracias Lucía. Serge, I think you are there, no?
Okay, very interesting case. And I hope that the diagnosis does not influence which medications you can prescribe. Probably is the case, but that would be unfortunate. So we're going to look it from the academic side, and then we'll see what can be done practically. If you see, it seems that the patient has evolved with the myelodysplastic changes. And we typically talk about transformation from MPN to acute myeloid leukemia. But of course, there is also a possibility that doesn't come in high percentages of evolving MDS in the setting of MPN. When we see this kind of changes, we always say, is there a contribution of therapy, hydroxyurea, to dysplastic changes, which is known to be an issue. However, this patient also has other reasons for suspecting that this is the disease evolution with rather complex cytogenetics. So the patient is clearly progressing. And we would say with the myelodysplastic features, you are even bringing a possibility of AML, and you are bringing a possibility of a rapid change. It's not very slow. So we would typically have this sign out as MPN with progression to MDS, and the pathologists would be calling this overlap syndrome, MPN/MDS unclassifiable. Now, this is not satisfactory many times for us to prescribe a medication like hypomethylation agents that would come to mind. In our setting, that is fine if you have overlap syndrome. If we need to have clarifications for therapeutic decision-making, then we would say the patient has transformed from MPN to MDS for easy of prescription. But basically, it is MPN that is evolving to MDS type of picture with a high risk of progressing to acute myeloid leukemia. You made this point very clear. The NGS can substantiate your case by showing additional mutations if you have something to compare with, right? I don't know whether you have sample from 10 years ago, but I had a case like this not too long ago where the patient acquired the SFC3B mutation, and there were more of the dysplastic changes, more of the ring sideroblast, and the bone marrow after 10 years and multiple bone marrows showing MPN was read now with overlap syndrome. And we decided to treat the patients with low dose decitabine, or you can use other cytidine because it's going into the myelodysplastic area, if you like. Now, ultimately, because this is 58-year-old, the outcome is not very good. So with NGS, you can substantiate the change by having these other mutations, and perhaps you identify also acquisition of targetable mutations like IDH mutations that you can try to use. But this lady definitely would need to go to transplant.
Okay, okay. Yes, Lucia, could you tell us how you started treatment?
We decided to begin Ruxolitinib and the Citabine.
A combination of both.
She began 15 days ago, and now she has a transfusion independence. She used to receive platelets almost every day, and she hasn't been transfused for the last 10 days. Some days after she began treatment, she wasn't transfused anymore.
Did she have symptoms in the spleen at the beginning, and did they go away?
No, almost no symptoms, just some fatigue, but it was not so significant.
So I'm glad that you actually did both. We don't talk about this much because it's pretty much impossible to prescribe both in reality here in the United States because of the cost. But you may be aware of the paper that was published in American Journal of Hematology with our clinical study of a combination of the both for this type of patients, MDS/MDS unclassifiable, where the combination of the two has shown possibility, because we didn't have a control group, a possibility of extending life comparing to historical controls. Because you decrease the myeloproliferation with the JAK inhibitor, and you are doing the therapy for dysplasia with hypomethylation agents. So this is actually extraordinarily good approach. I usually don't mention it because it's not realistic, but I applaud you for doing that. Nevertheless, the patient will not respond forever. I hope there are plans to do a transplant in some future.
We are searching the donor. She has no relatives, so we are going to look for the donor.
Yes, excellent case.
Okay, thank you, Lucia. So the next clinical case from Miguel Castro Ríos.
Con este se pasa y con este es el puntero.
Bueno, este es un paciente varón de 64 años de edad, asintomático, trabaja en el Senado. Como comorbilidades tiene una diabetes tipo 2, hipertensión arterial, hiperuricemia y una obesidad clase 2, dado por su índice de masa muscular. En junio de 1919, en una evaluación de laboratorio de rutina, se le encuentran 41.300 blancos con 75% de neutrófilos, con un hematocrito normal.
Miguel, 2019, ¿no?
Sí. Ah, perdón. 2019, perdón. Hematocrito 42%, eritro 27, plaquetas normales y una LDH levemente aumentada. En agosto del 2019 se le hace una biopsia de médula ósea que es hipercelular con hiperplasia megacariocítica y mieloide, con poca alteración digranulopoyética y con una fibrosis grado 1-2. El citogenético fue normal, la citometría de flujo no mostró clonalidad, con 1.2% de CD34 positivos. El BCR-ABL fue negativo y el JAK2 también fue negativo. Se le realizó un scan de abdominal que mostró solo esteatosis hepática y una esplenomegalia homogénea de 157 milímetros. Tiene un estudio cardiológico por EcoScan que mostró una fracción de eyección de 60% y placas en carótidas no estenóticas. Tiene una espirometría normal con un disturbio moderado de la difusión pulmonar y solamente en la tomografía de tórax tiene ateromatosis aórtica y leves opacidades intersticiales. Se realizó una Next Generation Sequencing y se pudo observar que el paciente tiene un 50% de ASXL1 positivo, SFR3B 45% positivo, y la otra, ¿cómo es la sigla?
ZBP1,
ZBP1 también positivo en el 47%. El paciente tiene una hermana que es HLA incompatible y tiene un hijo de 34 años, y en octubre del 2019 comenzó con hidroxiurea 1 gramo por día y dieta hipocalórica. En el último control tiene 2.770 blancos y se redujo la dosis de hidroxiurea. El paciente ha consultado con numerosos hematólogos y ha sido muy controvertido con respecto, primero, si está en condiciones de recibir un allotrasplante, y en segundo lugar, si corresponde hacerle un trasplante de un dador no relacionado o hacerle un trasplante con su hijo. Así que esa es la controversia y quisiéramos saber su opinión al respecto. Bueno, el diagnóstico, por supuesto, es una leucemia granulocítica crónica, que por las características del frótis y de la médula ósea es más cercano a una leucemia mieloide atípica, y los cambios en la Next Generation Sequencing demuestra que esto también da más a favor de una leucemia granulocítica crónica que una leucemia mieloide atípica. Bueno, esperamos su opinión, doctor.
Okay, this is another different case, which is very intriguing. Have you tested for calreticulin or MEPL mutation?
No.
Okay. Nevertheless, the patient has a bad genetic profile. And this particular case resembles a question that was asked after first part of my presentation today. What would you do in a patient who has otherwise lower risk disease and has a bad genetics? Because if we would, for example, hypothetically say that the patient has a myelofibrosis, let's say the patient is calreticulin positive, and you would then apply international prognostic scoring system at the time of diagnosis, and you would have one factor only, which would be white blood cell count over 25,000. I don't see any other one. That would be intermediate 1 risk disease. He's not symptomatic, he's not anemic, and the only one factor is white blood cell count, for which you gave him hydroxyurea to lower it. But then in this setting now you say, but your disease is going to be affecting you sooner rather than later because you have a bad genetics. So before we wait for him to progress, and progression will be probably anemia, it may be that he will progress with the spleen, but usually blood cell count is the one to go down. So blast may appear in the blood and the anemia may develop, and then you have, in a short order, a high-risk disease. When you have blast anemia and history of high white cell count, you would have a high-risk disease, and his life expectancy is short. So this is exactly the gray area where the information regarding the genetic complexity can push us to say, don't wait to be very sick and do the transplant sooner rather than later, which is difficult to say. The patient is doing well otherwise. So usually we have to wait for these problems to appear. The patient becomes anemic, not because of the hydrea, because of the disease, or the blast appear in the blood. That would move the patients to high-risk disease, and then the issue of transplant, yes or no, it's mute. It's always yes. Now here you don't have a donor. You have, if I understand, a haploidentical donor.
Yes.
Yes.
And so the question is the risk and benefits of this type of donor versus waiting for patients to die. I'm making it very radical because with the medications, when the progression happens, the patient becomes anemic, you give them some erythropoietin, the patient has blast going up, you give them some azacitidine. This is all fine, but the progression will mean that the progression started and will continue, perhaps at a slower pace with medications, but it will most definitely shorten life expectancy of the patient. We know that. So I am usually in favor of exploring any type of the transplant, perhaps not immediately. When the clinical presentation worsens, would be fine, anemia or blast, but to prepare the patients that the disease will change because of the bad genetics, and then to be ready to go with any type of transplant in a clinical study, perhaps, to try to save the life of the patients. Because then, if this is a high-risk patient in 6 months, his life expectancy is short. So I would work on that and while waiting for a clinical picture to worsen, and then the patient is mentally ready to say, yes, I'm getting worse, I need to do it.
Sorry, in this case, do you prefer to use Ruxo?
No, I don't see a reason
you
why
continue with the
hydroxyurea. You are only treating him for high white cell count, which is okay, but there is nothing else here to treat him for.
Okay. Yes, thank you very much, Serge. So we have the last clinical case. Florencia Negri from Paraná is going to present it.
Bueno, buenas tardes. Voy a presentar una paciente de 45 años que no tenía una historia importante de antecedentes clínicos. Sí venía siendo estudiada el último año por una anemia moderada. No tenía organomegalias ni síntomas B. Trae un laboratorio anterior con una anemia de 27 de hematocrito, 280.000 plaquetas y 8.100 blancos. Esto fue de diciembre del 2018 y cuando la conocemos en julio del 2019 tiene una anemia más severa con 21 de hematocrito, 26.900 glóbulos blancos con desviación a la izquierda y 500.000 plaquetas. Tenía en ese momento una LDH de 700 que es elevada y una eritropoyetina de 500. Le hacemos un estudio de médula ósea, bueno, nos costó bastante el aspirado porque era dry tap, pudimos finalmente tomar material. En la biopsia de médula, era una médula ósea hipercelular, que hablábamos mucho con la patóloga, que es la doctora Narváez, porque ella veía un fondo más parecido para un LMC, pero veía muchos megacariocitos que le parecía más de Phi negativa. Y además tenía una mielofibrosis grado 3, un grado de fibrosis grado 3. Tenía 1,4% de blastos por citometría de flujo, y en el citogenético lo que les parecía era una variante o una alteración 922 críptica, por lo que pedimos un FISH para BCR-ABL que fue positivo y un estudio molecular que también fue positivo. Bueno, queríamos saber si esto era una LMC con fibrosis o era una mielofibrosis primaria asociada a una LMC, por lo que el JAK2, que fue lo primero que tuvimos, era negativo, pero aumentamos el estudio, pedimos KLR y MLPL que fue positivo. Por score de SOCAL tiene un score bajo y los scores para mielofibrosis da un intermedio 2 por IPSS, intermedio 2 por DIPS y alto por DIP+. Lo que nos costaba un poco es quién era el responsable de la anemia de este paciente, quién era el responsable de los glóbulos blancos altos y quién era el responsable de la alta necesidad transfusional, si estaba haciendo la LMC o estaba haciendo la mielofibrosis. Empezó tratamiento con imatinib, eritropoyetina y llegó a recibir en estos 6 meses 14 transfusiones o 14 unidades. Después de 3 meses de tratamiento, el tratamiento fue bastante difícil por falta de entrega de la droga. La paciente sigue con requerimientos transfusionales. Empezó el imatinib en diciembre y la eritropoyetina. En enero habían logrado en un primer momento bajar los blancos, suspendió un tiempo la droga, volvieron a subir los glóbulos blancos, pudimos reiniciar el imatinib, volvió a bajar a 16 de hematocrito, 1.900 blancos con 20% de neutrófilos y 40.000 plaquetas. Tuvo casi 3 semanas suspendido nuevamente el imatinib y ahora actualmente está nuevamente con imatinib y la eritropoyetina que nunca discontinuó. Está con 23 hematocrito, hace 2 semanas que no se transfunde, 3.300 blancos con 70% de neutrófilos y 260.000 plaquetas. Bueno, nuestra primera pregunta es si está de acuerdo con el diagnóstico, y esto es una mielofibrosis primaria y una mieloide crónica. Si cree que los score pronósticos son aplicables en este caso, si hubiese sugerido otra terapia de primera línea, qué tratamiento alternativo propone para la anemia, y si considera esta paciente candidata para trasplante. Está en este momento en estudio para saber si tiene hermanos histoidénticos. Gracias.
Hi, Serge. So, do you have any comments for this case?
Yes, this is really an unusual situation. We looked at our own CML and MPN databases and found some overlapping patients like this and published our own experience. To have 2 clones at the same time at the diagnosis is extremely rare, but it is an interesting case to discuss in general, because we have seen actually more cases where 1 clone is absolutely positively sure that it is positive, right?
Serge, we lost the communication for 30 seconds.
Okay,
So
let me
could
ask
you
the
repeat the
question.
last part?
Can you hear me now?
Yes.
About the fish for BCR-ABL, how positive is, and did it go away or decrease on therapy?
De tratamiento adecuado.
So as she has been exposed only 1 month, he was not re-evaluated by FISH yet.
And we are absolutely sure that fish was positive.
Yes.
Yes, yes.
Yes, because molecular is positive too.
So it was confirmed by FISH and by PCR. Perhaps it can be repeated, although it has been only 1 month.
Yes.
Yes.
Okay. Now, so typically when we have overlapping clones present in the same patients, they would do very well with the therapy for CML, and highly likelihood with what you are trying to do with 400 milligrams a day of imatinib, that would be standard practice, highly likely that you will have extraordinary response. And that's why I'm asking what the response is, because if the BCR-ABL clone goes away as it's expected, then the residual myelofibrosis as a disease would be responsible, obviously, for the remaining clinical issues. And in that setting, you would then treat patients perhaps not only with erythropoietin injections, but change to danazol or change to thalidomide while you are continuing TKI for CML. And we have a number of patients on dual therapies where the TKI for BCR-ABL is extremely effective. Imatinib is good first choice. I would not do anything different. And with the elimination of the BCR-ABL, you face the reality of the MPN other disease, whatever that is. In this case, it seems to be myelofibrosis. The assessment of the risk with myelofibrosis or MPN is best done when you eliminate the CML part to see what actually is related to the myelofibrosis itself. And the presence of one disease versus others does not really influence either the management or the outcome overall. So in this particular case, if you were able to continue with imatinib and the fish goes to 0 and the disease is gone, and you continue with imatinib as its practice, you would then be able to reassess fully the significance of other clone and what does it do with the best prognostic assessment at that time, and decide whether the transplant is necessary, which may be, because you have not much medications for MPN here.
Yes, okay, we agree. Thank you very much. ¿Algún? Espera, un micrófono. There's a question for this case.
Yes.
A minute, please. No, acá.
What is your opinion about the transplant in this patient? Because if she persists with big anemia.
Yeah, so the best answer would come once the CML has been controlled. That is expectation, right? The expectation is that with imatinib, if it can be given all the time without interruptions, you would expect that the CML part is controlled and gone. Then you may reassess the prognosis for myelofibrosis and see whether this patient has intermediate to or high risk. If the anemia persists and you have another factors which you did not have, and no, actually there was a white cell count of 26, but you don't know whether it's related to CML or MF. Basically, once the CML is gone, then the reassessment needs to be done to answer the question about the transplant now or later.
¿Está bien, Pedro? Thank you, Serge. It's okay. ¿Alguna pregunta más? So, I think we don't have more questions about the clinical cases. There's the last topic is your presentation about the best of ASH, or what you consider most important that was presented last year in ASH meeting.
Okay, thank you very much. This is the last part. Do you see my slides?
Yes.
Best of ASH, the front. Yeah, okay, good. Okay, so I selected several presentations on PV and myelofibrosis, and I span from something that is perhaps immediately useful and some others that may come soon to you and be able to use, and some future perspectives. So let's take a look together. All right, the first one may actually have some implications right away. You see here what the study is all about. This is a study which is called a REVEAL study that follows in the United States in more than 200 clinical sites, a very, very large number of PV patients over time. The goal is to follow them for 3 to 5 years and see what happens. And this meeting, they were looking at as you can see, a hemorrhage in PV patients who were on anticoagulation with or without the aspirin. Okay, so 2,500 PV patients, and among them, if you just look at the table, you will see that there were some that were treated with aspirin, anticoagulation, or the combination of the two, which is at the bottom of the table on the left side, right? So first of all, not everybody was on aspirin for some reason. Remember, this is observational study, that's how it is. And small proportions were on anticoagulation or on both together. And these people were then followed. In terms of the preference of the doctors, which anticoagulation to use, you see this on the right side. So the new anticoagulants are not often used, but they're used in quite a good number of the patients, nevertheless. And this is what happened. Hemorrhagic events in this group of people. The GI side, the GI is the leading cause. And remember, this is the prospective chart review. So I don't have the details. What I showed is all I have, but it's intriguing nevertheless. So I can't really give you much more details. What kind of gastrointestinal bleeding and what degree of the bleeding. What we have here is all I can show. And here is the most important part. You see in the bars that the combination of anticoagulation and the aspirin together has a higher rate of the bleeding than any other group. And this risk of hemorrhage with the combination of aspirin and anticoagulation was independent of the platelet count, meaning very high or very low. So obviously, observational study, not a study of two agents versus one agent or anything like that, just the observation that may have some implication on what we do. Because I am often asked, and then I consult with my colleagues in benign hematology department, what to do when the patient with PV on aspirin and phlebotomy has a blood clot. We do then, of course, the anticoagulation, and do it stop or do not stop the aspirin. Not that this study will give us the answer, but gives you the idea that we need to think about it and perhaps devise the studies that will determine it for sure. That's on this part. Okay. The next study is about the medication that was approved in Europe for polycythemia vera. People often go online. What happens here in the US, many patients come and say, hey, this was approved in Europe, and when can I get it here in the US? It may be something like that happening with your patients. This is the ropeg interferon. Ropeg interferon is an interferon that is a little bit different than other other interferons that we have. This one is given under the skin every 2 weeks, and supposedly after 1 year of therapy, you can even go to once a month. It's very slow release, and it's different pegylated form that is attached to interferon. So it was approved in March, actually. The opinion of approval was given, as you see, in 2018, and it was approved for PV patients without symptomatic splenomegaly. And it was approved based on ability to achieve complete hematological response. Complete hematological response, not the molecular response or anything else, just complete hematological response. Now this study, which is rather complicated, has been updated to tell us about the benefits long term. So not to go into such a great detail, but the patients were randomized, if you see in the middle of the slides, to ropeg interferon or Hydrea. And I'm not going to go in details about the numbers or percentages, but the study has been following these people more or less randomized for a much longer period of time than 1 year. Efficacy data that have been presented at ASH was after 48 months and safety up to 64 months of therapy. This is the result on complete hematological response. This is what led to approval. This is percent responders, complete hematological response, and you see the time frame. This is 0 at the beginning, obviously day 1 at the beginning. This is 3 months, 6 months, 9 months, and it goes by 3 months all the time down the X axis. In the red color is the percent responders on the ropeg interferon, and in green is hydroxyurea. You see that hydroxyurea is more effective at the beginning, but then the interferon catches up, and after about 2 years, the interferon is superior and maintains its superiority to hydroxyurea. Now, the label does not say one is better than the other, or use this over that. And as we know, the guidelines say in the United States and Europe, for PV, use one or the other. So this is along the lines of that recommendation. The label is for PV without spleen, with the goal to achieve complete hematologic response. We have a lot of discussion about this first part, where Hydrea is much better. What do you do with the people who are on interferon and are not controlling the blood very well? Well, you can phlebotomize them, but that is open to debate. It is on the market in Europe. And the thromboembolic events were described at the bottom of the slide, saying that both arms had very low level of thromboembolic events, suggesting that, yes, it is doing the job in controlling the blood cell count, which would lead to control of the thromboembolic events. That's fine. Now, what the emphasis was in that presentation on the molecular response, which we do not, again, use to judge the efficacy, but it is a hot topic. We all like to know about it, and it was presented. So upper part, ropeg interferon, this is JAK2 allele burden median, and then it's going down. The hydroxyurea, you see what happened with that in a gray. And so the final verdict is here. The JAK2 V617 is less than 1% by the sensitivity to test negative in about 14% of the patients. And this is what actually is the more important. Not everybody who has undetectable JAK2 mutation has complete hematological response. So 2 patients do not. That actually gives me the reason to keep saying, as I was saying before, that the molecular response is not the endpoint of the interferon therapy. It is the hematological response that we are looking for. So we're going to be learning about this much more over time, but that was kind of interesting to me to share with you because the drug is approved in Europe for PV. And the last part on PV, this is number 3, is something that is coming. This is just one slide after this one. This is the analysis of a large database of 90 million patients in the United States, among which 70,000 had a PV. So basically analysis of the outcomes of the 70,000 PV patients in the United States, where the artificial intelligence, the large computer, was analyzing every single bit of the information, not only those that we would say perhaps it's informative for the thrombotic event or for success of the therapy, like the history of thrombosis or the platelet number, everything that was known about these patients, every single point in time over 10 years period was synced into the computer, and the computer was telling us what the risk factors are. A tool for discovery of new prognostic factors. The one piece of that was this one. This is quite interesting. Predictive modeling to predict hydroxyurea treatment failure. Okay, to predict the failure of therapy. We have never ever done anything like that. We always predict who has thrombotic event or will have it and what to do about it. But this is the prediction of the treatment failure, and there are 2 factors that came up. If you see, number 1 is phlebotomy dependent. And now we realize the connection with what we were talking earlier on management of PV, where the guidelines say when you start cytoreductive therapy, you should eliminate need for phlebotomy. This is, to me, rather incredible that the large computer analyzing hundreds and hundreds of thousands of data would come up with the most important factor. If you are treating patients with hydria and you still need to phlebotomize, that's not good. The next factor is RDW, a new factor that has significance, which we are discovering. You combine phlebotomy dependence with RDW and you can predict, possibly predict, hydroxyurea failure. That needs to be prospectively validated, of course, but it's very new for the field application of the artificial intelligence. That is being done in some other hematological conditions, but to me, I think this is the first time I see it in the MPN, and it's providing perhaps useful information. Okay, moving on to myelofibrosis. Fedratinib was approved in the fall of last year in the United States for myelofibrosis. This was August 2019, and it was approved for intermediate to or high-risk myelofibrosis. Similar label to ruxolitinib. Ruxolitinib was approved for intermediate and high-risk. This one is for intermediate to and high-risk. A recommendation is to utilize the one single dose, regardless of the platelet numbers, 400 milligrams a day. And the one aspect of the safety that is vivid right there when you read about the drug is the bullet number 3 on this slide, a black box warning, Wernicke encephalopathy, because of possibility of interference of fedratinib with uptake of thiamine from GI tract into the patients. And one needs to measure the thiamine level before you give the drug and monitor the thiamine level while you're giving the drug to have this under control, because there is a very small risk of having the neurological toxicity. Now, this drug was approved based on the Jakarta study, published many years ago, and this is a very old study. If you look at the middle of the slide, placebo arm and then fedratinib 2 arms. It was done before ruxolitinib was approved, so there is no comparison to ruxolitinib head-to-head in frontline setting. And if you look at the lower part of the slide to the left, this is a splenic response, and on the right is the symptomatic response. So on the face value of the results in terms of the efficacy appears to be similar to ruxolitinib. What was shown at ASH is this extension of the analysis saying, yes, the drug is effective for spleen and symptoms in frontline setting, but look, it is effective with the same dose, 400 milligrams a day, without adjusting it for the platelet number, in the patients that have platelets between 50 and 100. And so this is circled here, 50 to 100, the SVR, the spleen response is about 35%, and symptomatic response about 31%. So less cumbersome for management when we come to the platelet issue. That was the point of the whole abstract. Now, this drug does have some other toxicities, unfortunately. Diarrhea, vomiting, and nausea is quite prominent. You can see in many patients that's the problem. And we think that is because the fedratinib causes inhibition of FLT3. And FLT3 inhibitors as a group, as a class, causes GI toxicity. So that is the case here. And we give patients nausea medications to have handy in case they have significant nausea. In terms of myelosuppression, which is in the lower part on the left side, anemia and thrombocytopenia appear to be at the same level as what you would expect with ruxolitinib. So a little bit more toxicity here, GI and neurological, and about the same with hematological. Now, where do we feel this medication might be useful? And I think that the maker of this drug feels the same, because I see what's happening in terms of them telling people how to use it. This is in a second line. After ruxolitinib, what you could see in the right lower corner is the big box. It says reanalysis employed a more stringent definition of Rux failure. This was an attempt to objectivize the ability of fedratinib to work in a real patient, in a patient with a real failure, not just because somebody says so. It's as simple as that. And the result in that part was then spleen response of about 30% and the symptomatic response in about 27%, with the same toxicity as I was describing it. So this is not on the label. It doesn't say for second line, but it is being discussed that this is perhaps where it should be used in patients who are failing ruxolitinib with a good red blood cell count and good platelets, because it is myelosuppressive. And the drug actually, the cost of the drug here in the United States is double of the ruxolitinib. So I think that even the maker of the drug is positioning it from commercial side for use in second line where there is nothing else to be used. In this second line as well, the platelets do not really matter. This is the group here circled in red, platelets between 50 and 100. Still decent response, about 36% response and 39% for the symptoms. So less cumbersome when it comes to the dosing. Where are we going with the JAK inhibitors? If we have on the left side in green approved therapies, fedratinib approved in US only. Then we have in the middle of the slide pacritinib, which is being studied in patients with platelets below 50 around the globe for spleen and symptom control. Momelotinib, I mentioned before, it's a phase 3 study in ruxolitinib failures for control of symptoms and anemia. And fedratinib actually is being studied in 2 studies to get a label for the second line. These are called freedom studies, one in US and one in Europe. This is another poster that I mentioned before as important for clinical practice. Phase 2 ongoing study of thalidomide and ruxolitinib. So 12-week run-in phase with ruxolitinib alone, or if the patient is on ruxolitinib already for more than 3 months, that's okay. So basically ruxolitinib exposed patients that are anemic were allowed to enroll, and thalidomide 50 milligrams a day was add on. No more just continuous thalidomide and no prednisone here, just on ruxolitinib with anemia add thalidomide. And it's very small study so far, and it's only in 2 centers, but because of these results, it's going to be expanded, and now it's going to be supported by the makers of these drugs. So far, it was investigator-initiated study. So small number of patients, but intriguing results. You can see here on the left side, increase in hemoglobin, and you can see in the right side, surprise to all, increase in the platelets. Actually, 75% of the patients increase the platelets from baseline to significant level. So that part actually is quite intriguing because we don't have any drug for platelets at all. We did a study with thrombopoietin mimetics, Promacta, not published yet, but it didn't work. So I don't have any medication to suggest with any good track record of increasing the platelets. So, but because of these results, we talk about adding thalidomide 50 milligrams a day to ruxolitinib in these people, and possibly effective, as you can see. And then we are almost at the end. Luspatercept is the drug that probably many of you know as a drug for anemia in MDS. It is expected to be approved for MDS soon here in the United States. The same drug is being studied in myelofibrosis. And the study was for patients, and this is perhaps a little bit complicated, but it was done properly. The drug is inhibiting basically the TGF-beta pathway in an indirect way, allowing the terminal erythroid maturation. So that would be different than erythropoietin stimulating agents, which is shown on this slide. That would lead to increase in the red blood cell numbers. The study was a little bit complicated, and if you just look at the left side, there were patients that were anemic but no transfusion requiring, and patients that were transfusion dependent. And then they were able to be or not to be on ruxolitinib. So you had a number of cohorts here that were analyzed separately, and it took quite an effort to understand what's happening here. The bottom line is that the goal was increase in hemoglobin of 1.5 grams for 12 months, or making people transfusion independent. And that actually happened in a good proportion of the patients, and particularly in patients that were on stable dose of ruxolitinib. This is the group here on the right side. The primary endpoint was in red color, in blue is partial response in a number of patients here. So the company, that is a Celgene acquired by BMS, they announced at ASH that there will be phase 3 randomized study starting this year for anemic patients that are on stable dose on ruxolitinib to improve the anemia. So it will be specifically for patients on ruxolitinib, stable dose, with anemia to improve the anemia. That is about to open, I would say, by the end of the year around the globe, and hopefully in Argentina as well. And there are many other interesting drugs. I just put here some of the abstract with the new drugs, or all drugs in a new role, like deferacerates in the iron overload patients. But many others are being studied, and we're pursuing them. I was trying to, in these 15-20 minutes presentations, to pick those that might be more useful for you than the others. So I thank you so much for listening to the end.
Okay, thank you, Serge. Is there any question? ¿Alguna pregunta? So, if there is no question, perhaps I want to thank you, Serge, for sharing your experience and all the data you gave us. I want to thank you for coming. Our colleagues that share their clinical cases as well, and my MPN study group from the Sociedad also that collaborated in organizing this meeting, and of course to thank Novartis who also helps us in this meeting as well. So perhaps besides the sharing your data, we might have you more, I have to say, más cerca, closer, in order if we have some doubts or perhaps want to ask from a clinical case. After this meeting, we might touch with you and ask the question.
No hesitations at all to contact me. This is my email here. I will be very happy. And I want to thank organizers, yourself, and the colleagues in the public for allowing me to participate, even though I'm not there in person. I will try to make it up and see you in a year or 2 years in person so we have a good time. And I hope that this was useful to you. Again, thank you so much, everybody, and be in touch. This is email. And if you need the slides, if you don't get them, I'm happy to share all these slides with you.
Okay, thank you very much, and an applause.
Thank you.
So I hope you have not to work this weekend after this heavy week you had from your tour through Argentina.
We will take a little break for sure this weekend, but it was a pleasure. Thank you. Have a good day, everybody.
Well, bye-bye, Serge. See you
Bye.
later. Bye.